is available at the Covidian booth. It's called Interventional Treatment of Venous Disease. And in there are 4 articles written by interventionalists. Michelle also is published in this as well about how to start a vein practice. So please make sure you come by the Covidian booth and pick up a copy of this. I think you'll find it very interesting. And with that, I would like to introduce John George.
Thank you. Good afternoon, everyone. We'll try to keep this really informal, and if you have questions, please feel free to ask, and enjoy your lunch as you're listening to this. So again, my name is John George, and thank you, Covidian, for sponsoring this, and thank you all for being here today. And the title of today's talk, at least my component of the talk, is Identifying and Managing Patients with Superficial Venous Disease. So just to get an idea of who's here in the audience today, how many of you are cardiologists? Okay, and how many radiologists? Vascular surgeons? Podiatrists? All right, so we've got a mixed group of people here in the audience. And I'm going to talk about how venous disease is prevalent and how prevalent it is and why all of you should be involved in treating these patients. So looking at the prevalence in the United States, we have over 11 million men and 22 million women between the ages of 40 and 80 years that have varicose veins. We have about 3.6 to 8.6% of the population, or over 2 million adults, that have more advanced chronic venous disease. And that includes ulcerative changes in the lower extremities, or venous ulcers, stasis ulcers. So this is a large population that we're talking about. At least 20,556 patients receive a new diagnosis of venous ulcers every year. And the medical cost associated with treating chronic venous disease has been estimated to be between $150 million and $1 billion annually. And this is a chronic cost that accumulates over the length of the lifespan of the patient. So the question is this really just cosmetic therapy, or are we really impacting patients in their quality of life? And that's what I'd like to get through in the next few slides. So it's really more than just a cosmetic problem and an emotional burden. There are patients that describe discomfort and pain, loss of working days and disability, deterioration of health-related quality of life, loss of limb, and even life expectancy. And the references are down below that you can refer to, but these have been directly correlated with chronic venous disease. What are the risk factors for developing varicose veins or chronic venous insufficiency? Well, older age, we know, is one. Family history, deep venous thrombosis, and you've had a bunch of lectures this morning about DVT and chronic venous insufficiency. History of phlebitis, and then obesity, standing occupation, pregnancy, and female gender. So if you think about these risk factors, think about how many of these patients you're exposed to on a daily basis. I'll tell you that for those of you that are in cath labs or angio suites, and for myself in particular, it's unbelievable the number of referrals I've got from within the lab itself. And these are all people that have a standing occupation, prolonged duration for several years, and then obviously female gender and multiple pregnancies add to that. Other risk factors: smoking, hypertension, contraceptives, hormone replacement therapy. All of these have been linked, but not really sure how well they correlate. So I'll quickly go through the anatomy. We know that there are 3 levels of veins within the venous system in the lower extremities. We have the superficial compartment, the deep compartment, and then the perforators that communicate between the two. And it's important to understand this anatomy to treat the disease appropriately. So if you look at this, I'm not sure that I can point from here, but if you look at that saphenous vein, it rides right under the dermis layer within the saphenous fascia and the deep fascia. And then you have the deep compartment below, deeper to the muscle layer. And you have the perforators that communicate through that layer between the deep and the superficial system. So what about the physiology within the venous system? Well, we know that veins, to function appropriately, have to do a lot of work. They have to overcome hydrostatic pressures, intrathoracic pressures, intra-abdominal pressures, to be able to deliver blood back up to the heart, which is what they're responsible for venous return. And we know that to do that, there are 3 criteria that have to be fulfilled. One is that they have to be unobstructed. Second, that they have to have functional one-way valves. And third, that you have to have effective muscle pumps. And if you don't have all 3, you don't have adequate venous return. And you'll see in the figure that's off to the right that hydrostatic pressures in the distal foot can get as high as 100 millimeters of mercury while standing, because that's the pressure that these veins have to work against to get the blood back up to the heart. So obviously unobstructed. We know that if there's a clot within the venous system and it is obstructed, then that can lead to insufficiency, because obviously there's a pressure buildup within the venous system. They get dilated, engorged, and now you have reflux through the venous valves. If you don't have functional one-way valves, obviously, if you have incompetence of these valves, you have reflux. And then finally, muscle pumps. We're totally dependent on our calves to squeeze these veins within the legs to return blood back up to the heart. So if you're sedentary or if you have ineffective pumps, then that obviously is going to affect venous return. So what are these symptoms, and are they real? Well, they have been validated that these patients that come in have symptoms of heavy legs, sensation of this swelling, pain in their legs, night cramps, pins and needles. So as you look at these symptoms, you realize that they are very vague symptoms, that it's hard to elicit what truly is the cause or the etiology of these symptoms. So it's important to, again, get into that elaborate history to figure out, and obviously the signs and clinical exam that are important in identifying patients with chronic venous insufficiency. So like I tried to point out, that there is more than just a superficial cosmetic appearance issue, but there is as well a clinical implication. And that's what we'll get to next. What do you look for in the office? So there is a classification system that you can use. It's a CEAP classification system. The CEAP stands for clinical, etiologic, anatomic, and pathophysiological. But typically, we just use the C component of the CEAP classification, and that goes from 0 through 6. And for those of you that treat arterial disease, it's similar to the Rutherford scale in the sense that it's a gradation or ability to quantitatively, objectively assess venous disease. And so C0 is really no symptoms at all. C1 is when they have telangiectasias or reticular veins, so spider veins, very small venous manifestations of CVI. C2 is when they have visible and palpable varicose veins that are much larger and more obvious. C3 is when you have edema of the legs and engorgement of the lower extremity, but yet no skin changes. C4 is when you start having skin changes, trophic changes of the skin that can include atrophy blanche and lipodermatosclerosis and a variety of things, eczema. But once you start developing skin changes, that's C4. C5 is when you have a healed ulcer, and C6 is an active ulcer. So how do you assess these patients? Once these patients come in and they demonstrate these signs, what do you do to evaluate them further? Well, an ultrasound examination is the first line for screening. And what you're looking for in an ultrasound exam is the presence or absence of reflux in the GSV. There is, you're looking for reflux in the SSV. I'm not sure what that's coming from. No subliminal messages there, really. in the SSV, so the small saphenous vein, so you have the great saphenous vein and the small saphenous vein, you're looking for reflux in these segments. You're looking for the presence of perforators, and again, not necessarily perforators that you may treat, but just to identify them, because they may be associated with ulcers that the patient may have. Competence of the deep venous system, because if it's obstructed, if the deep venous system is obstructed, you definitely don't want to treat the superficial system, because the patient's completely dependent on the superficial system. And patency of the deep venous system. So on ultrasound, what you're looking for is a reflux and again, I can't point to it, but it's a reflux at the bottom phase that dips below the line, and that's the reflux. And how long does that last on ultrasound? And anything greater than 0.5 seconds or 500 milliseconds is considered significant. And so that demonstrates whether the GSV or the SSV is refluxing. So how do you treat these patients? Well, the main line of therapy is compression. As you know, this is mechanical therapy to try to alleviate the pressure and the engorgement of these veins within the lower extremities. So if you can have graduated compression from the foot all the way up, and the higher up you can go, the better the effectiveness of or the efficacy of compression. And so that alleviates some of the discomfort. Obviously, if that doesn't work, and then other conservative therapies are elevation of legs, and this is a little bit extreme, but keeping your legs elevated at the level of the heart or reducing the amount of work the legs have to do against gravity is helpful in alleviating these symptoms. So staying off your feet, keeping the legs elevated, compression. That's the mainstay of non-invasive therapy. Obviously, if that doesn't work, you have to go to more aggressive routes, and that's where this procedure comes in, the Venous procedure with closure fast catheter, and that's what I'm going to talk about. So this is primarily radiofrequency ablation for chronic venous insufficiency in the superficial system. So what is the concept? How does this exactly work? Well, this is the heating. The concept is that you heat the vein wall by conduction from the heating element from a generator that delivers RF energy to the tip of the catheter in a coil. And the heat actually destroys that endothelial layer and then causes this deposition of fibrin and causes fibrotic sealing of that vein segment that has been treated. And so the idea is that you disrupt the normal intima of these veins with heat from RF energy, and then you close it down permanently. So acutely, you have endothelial denudation, you have thrombus formation within the segment that's treated, you have thickening of the vein walls, and an inflammatory process that occurs. And then after 6 weeks or over the chronic period, you have actual fibrosis of the vein wall that causes the permanent closure. So what is the equipment that's required? You require a generator. This is a picture of the closure generator. It delivers RF energy through the closure fast catheter. The normal operating range is about 15 to 40 watts. And you treat for 20-second cycles. And there's any number of segments that you can treat that I will get through. The target temperature of the tip of the coil is about 120 degrees Celsius, so it gets pretty hot. This is what the catheter looks like. It has a 7-centimeter heating element, and there's also a shorter coil, a 3-centimeter coil that's available for treating shorter segments. You have a handle that has an on-off or a start-stop button and a port at the end of the catheter to deliver a wire to get through tortuous segments. So the steps for treating a patient, first is preparation of the room. It's very important. The atmosphere in the room is extremely crucial. Obviously, having all the equipment is one, but the second is also to make the patient comfortable. You'll find as you're doing these procedures that these veins are extremely spastic. If you stick them multiple times, they tend to spasm and collapse. Or if the patient's cold or uncomfortable and really nervous, then they tend to be small as well. So it's important to keep that patient comfortable. You use a table with Trendelenburg capability, so you're able to drop the legs so you can engorge the veins in the lower extremities as you get access. And then the room temperature and keeping the patient comfortable, whatever it takes, whether that's light music or looking out the window. Doesn't quite work where I am because you're not looking out at much. But if you're on the beach, maybe that'll work. Patient preparation, obviously you want to review the patient chart, know their history, whether they have had a prior history of phlebitis, whether they've had a prior history of DVTs, any medications that they're on, review the ultrasounds that they've had, and then obviously patient consent. Then you get to pre-op vein mapping. So on the day of the procedure, you use ultrasound to map these veins. And this is where you get to bring out your artistic skills, your creative talents. If you want to map them out with paintings on their legs, you might as well go ahead and do it. I don't quite go as far as the picture on the right, but some sort of marking, so you can mark the point of access, mark any points of aneurysmal segments that may need to be treated additionally, and perforators need to be marked. Then you position, prep, and drape the patient, and this is in a supine or prone position. If you're treating the GSV, which is along the medial aspect of the leg, all the way from the groin to the foot, then you have the patient in a supine position. If you're treating the SSV and the back of the leg, that goes from the foot all the way up to the popliteal vein along the posterior compartment, then you'd have them in prone position. Sterile prep the entire lower extremity circumferentially, and you can consider warming. Like I said, the temperature is important. And you drape the patient in sterile fashion. And then you get access. Micropuncture needle, ultrasound guidance. The picture on the right shows you on top shows you the needle entering the vein in a longitudinal plane. And the picture below shows a wire across within the lumen of the vein. So it's really ultrasound-guided access. Again, they're very superficial, and micropuncture is recommended. Once you have access, you place a 7 French sheath in. The catheter is then inserted into the sheath, and then you visualize the tip of the catheter with ultrasound as you advance it. You advance it to the saphenofemoral junction. You want the tip of the catheter at least 2 centimeters from the saphenofemoral junction and away from the superficial epigastric vein, which drains that proximal segment so you don't form clots. And once you've visualized it with the tip of the catheter away from the saphenofemoral junction, you start delivering tumescent. Tumescent is the anesthesia that's delivered. It serves multiple purposes. One is to prevent the patient from having any pain as you deliver 120 degrees Celsius of heat. The second, it acts as a heat sink, so it actually absorbs a bunch of this heat, so it doesn't damage any structures adjacent to the vein, any nerves. And the third is obviously just to prevent the skin from getting burns from the heat. So again, as a heat sink, it prevents the heat from being transmitted from the vein to the skin surface. This is an ultrasound showing the tumescent around the vein and the catheter. And you deliver tumescent anesthesia through the entire segment of the vein that's to be treated. And here you visualize on ultrasound the saphenofemoral junction and the collapse of the vein right in the proximal segment with the tumescent anesthesia around the catheter tip. You deliver energy. Again, it's over 20-second cycles from the tip of the catheter, 7-centimeter coil, so 7 centimeters at a time. After 20 seconds, a very proximal tip you treat twice, and then one treatment along the rest of the greater saphenous vein. And so here's a picture where access is obtained right below the knee, and you treat over a period of 7 cycles as you withdraw the catheter. Twice treated at the most proximal segment, and then as you pull back, one treatment at each site. As you're pulling back, you also compress with the ultrasound probe so that you get adequate contact between the heating coil and the vein wall itself, and so that you ensure that inflammatory process and endothelial denudation. Post-op, it's pretty simple. We do compression. We encourage compression with stockings. We do an ACE wrap for 48 hours right after the procedure, compressing the entire leg, again from the groin all the way down to the foot. We tell the patient to switch over to their compression stockings over the next 3 to 4 weeks, and they return for an ultrasound in 4 weeks. Within that first week, you'll do a DVT study to rule out a DVT, just to make sure that there was no extension of the thrombus from the saphenofemoral vein, or the greater saphenous vein, into the saphenofemoral junction, and then a venous insufficiency study in 4 weeks just to confirm closure. Complications, there are a whole list of complications that are listed: vessel perforation, thrombosis, PE, phlebitis, infection, nerve injury, skin burn. But I'll tell you that I haven't really seen any of these complications, and the importance is to ensure by ultrasound that you know where the tip of the catheter is, and that you deliver adequate tumescent anesthesia before the procedure. And all of these can be avoided. So now we get to the decision-making part. Why should I or my practice treat veins? Why is my specialty even qualified to treat veins? And I'll tell you as a cardiologist, and for those cardiologists in the audience, that's a valid question that people ask. Why, if you're treating the heart and the vascular system, why would you get into veins? Why am I doing this, and why do I want to be involved? Well, I'll start with a case, and I'll tell you why I want to be involved. This is a patient that was sent over to our practice for a referral, and this was for a non-healing venous ulcer. It was an 80-year-old lady with renal insufficiency and multiple medical issues, but had this long-standing ulcer that was non-healing. So coming to this endovascular clinic, this was at an outside hospital, got evaluated, and on screening for peripheral arterial disease found that she had significantly abnormal ABIs of 0.4. So she was brought in for an angiogram, which this screen on the left shows you that she had a total SFA occlusion, the distal segment going into the popliteal artery, with reconstitution below the knee with single vessel runoff through the anterior tibial artery. And so this was appropriately treated with endovascular intervention, opened inline flow into the lower extremity, had actually 2 vessel runoff when everything was done, received a stent in the SFA, and she did great, except the ulcer never healed. So she came back again within a year, and she developed restenosis in the infrapopliteal segment, had atherectomy performed at that point, had a drug-eluting stent placed in the lower extremity. This was over 3 or 4 procedures that this patient had, and the ulcer never healed. And so here's the picture of the ulcer when I finally saw the patient, and this patient had eventually come for a second opinion because she never got better. And so if you look at this ulcer, again, the importance will be to determine whether this is an arterial ulcer or a venous ulcer, and we don't have all the time to get into that, but this gator region, this medial malleolus ulcer, is classic for venous ulceration because it's a distribution of the great saphenous vein. And so we did an ultrasound. We saw that she had significant reflux. We also saw that she had a perforator right under the ulcer, and also another one 23 centimeters from the ankle that was refluxing. So we treated it. We did RF ablation with the closure fast catheter that I showed you. You see that there's complete closure of the great saphenous vein just distal to the junction. And we also did RF ablation of the perforator. And this was a patient 6 weeks later, had almost completely healed for what was non-healing for over 2 years. And this is the reason why I think you should be involved in venous management, because these patients come to you. You already see these patients, and a lot of them are misdiagnosed. There's not a lot of education about venous disease, and that's the reason why we're having this symposium, or this to again educate and to be able to treat these patients is impressive. I'm running out of time, so I'm gonna skip this because I think Michelle's gonna cover a lot of this, but again, there are a lot of reasons why you need to be involved in venous disease, but it starts with the patient. There are a lot of other advantages to the physician as well, with obviously not having to wear lead and having lighter days and quicker procedures, very satisfying. A lot of opportunities to grow within this field. And I will actually stop there, and I will let Michelle come up and continue the rest of the talk. Thank you.
Well, thank you for having me here, and I always get excited to do these talks. I've been doing this for several years and am pretty passionate about getting these patients identified and treated. Do you have my slide set up? 1 minute. So my part of the talk is going to focus on the identification of the patients, and then also trying to align your practice to find these patients and get them treated and educated in a more efficient way. So first, what is our motivation for being here? Several motivations. First, if you're a provider of these venous treatments, trying to increase the identification of these patients that are already within your own practice and in your community. How do I brand and market my program so I can grow that and be known as a vein center? Your referring partners, educating them to try to, again, get more of those referrals that are coming into your office from already established referring physicians. Knowing how to educate them and provide options for their patients in their practice. And build on their treatment that they already have on, or their knowledge and diagnosis of venous disease with the referring physicians. And I think one of the reasons why we're all here is because we recognize the disparity that exists between patients that are identified or even have complaints and maybe not even identified yet, and to those that actually get treated. And I call these patients our peripherally challenged or physically challenged patients, because a lot of times it does affect their functional ability. And being in the healthcare community, we always want our patients to be up and moving and walking. Exercise is good for you. And much like our peripheral arterial disease patients, our venous disease patients have difficulty doing this as well. So finding the patients who will benefit. The who part we know who is at risk for venous disease. Their occupation, female, obesity, all of that. We already know what the symptoms are that are suggestive of the claudication or reflux, although they are very vague. And then the physical exam findings for it as well. But are we conscious of these with every single patient that we see in our practice? You know, it's Friday afternoon, you're already hour behind, you're trying to run through your patients, kind of get caught back up because you got to get out of there on time. Are we asking and addressing venous disease with every single one of our patients, even if they do have these risk factors and they do have maybe some subtle symptoms or signs of venous disease? And it takes time. So how do we do that? That's more the question. Having a knowledgeable community, including your patients and your referral base that's there. Again, having that educated consumer. Create a culture and a brand in your own practice, and we'll go over some more detail of how to do these things. An efficiency of the process that's sustainable is definitely key. You don't want to spend all this time and energy creating a program to identify these patients, and then slowly over time it fizzles out. So that's the other piece that I hope you take away from this, is not only how to create it, but how to keep it sustainable. And then establish a network or team approach. We all know there's power in numbers, so if you're not the only one in your practice that's trying to stomp out, the 30 million people with venous disease, it'll be beneficial. So there are 3 gaps or areas that we need to be knowledgeable of in trying to create this program and identify these patients. And the first I want to talk about is the patient gap. So we already know about hereditary and how genetics can play a large component of who gets venous disease. So patients are notorious for self-diagnosing themselves, and they may say, well, my grandma had this, my mom had this, my sister has it, it's just what's in our family. Maybe they had treatment, and maybe it was painful in the past, and they didn't do anything, and it didn't really help, so they don't seek the treatment for it. They're just going to give me compression stockings. They're just going to tell me to elevate my legs. Or they believe it's a cosmetic problem, and they're not going to seek that treatment because it's not covered by insurance. So these are all those myths and biases out there that our own patients have that may prevent them from actually addressing the problem with you and bringing it up to you. Compliance. How many patients do you put in compression stockings and then maybe they never bring up their venous disease again, or they don't talk about it again? Or maybe not in your practice, but maybe your primary care physicians. Maybe because this is what they do. They give you the compression stockings and that's all they can do for it. So we need to make sure that we're capturing those patients so they don't fall through the cracks either. And then a lack of knowledge on the options and treatment that are now available. I mean, these things weren't available 20 years ago to our patients. The next gap is the referral gap. Venous disease is underdiagnosed, it's undertreated, underappreciated, and definitely a lack of awareness on the treatment options. And I used to joke and tease that peripheral arterial disease was the redheaded stepchild of the atherosclerotic diseases with coronary and carotid disease. Well, I think over the past 10 years or so, we've done a great job in incorporating PAD and understanding the implications of that disease process and getting these patients identified and treated sooner. Well, I now say that vascular disease is the redheaded stepchild of the vascular system diseases. And with that referral gap too, just to go back to that, primary care or patient or physician referrals that don't see venous disease every day, don't deal with it, so don't treat it, they may not be up on all the latest and greatest technology that's out there. So it's up to us to educate them and to help them see that there are more options for these patients. Then the practice gap, and Dr. John George did talk a bit about this as well. The belief that it's necessary to treat veins. So if you're in a cardiology practice, I'm sure you've gotten that from maybe some of your partners who aren't treating venous disease. Why are we getting into this? Why are we getting into veins? Veins are not arteries. They're very different. The belief that it's debilitating and that there are consequences for our patients. Nobody likes to change, and yet even to keep that change sustainable. And it's that whole myth that it's gonna add a lot of time to my already busy patient schedule and load. How am I going to address this and now look for venous disease with our patients? So these are some of those myths and biases in your own practice that you need to address. And the implications for all the practice members, including your interventional physician. So who's going to do these procedures? If they're in the back doing radiofrequency ablation, who's going to be seeing those patients they typically saw during that time? Or who's going to be picking up the volume in the cath lab if they're not in the cath lab doing procedures? And the whole logistics of it. Okay, where are we going to put these patients? Where are we going to do the procedure? That was one issue that we had in our own practice. Where are we going to create this space? Where are these patients going to, is it going to be the same waiting room? How do we flow them through our office? So these are all things that you need to think about. So CVI is important to your peripheral practice. In our journey at Eastlake, when we started looking at peripheral arterial disease, and we were really doing a great job with identifying our patients and educating them, we found a lot of venous disease. And that's pretty much what prompted our drive that, we're telling patients we can't do anything for the venous disease, go see your primary care doctor, maybe try compression hose. We were turning all those patients away, and that was an eye-opener for us. And that might be one thing to address with your partners too. We can do something to help these people. So you have to be the vascular advocate, not only in your own practice, with your patients and with your referring community, and you should get to know some of these statistics because facts always can help drive things. It's not just you wanting more patient volume and more referrals. There really is a need out there, and making sure that they're aware of that. So again, the volume is there. We are going to have more and more people with venous disease as we all age. Complications, it definitely affects their quality of life. Morbidity and debility, work days lost. Again, Dr. John George did speak about this as well. And I think in the future, we're going to find that there's not going to be cardiology and vascular and all this. I think we're going to become circulatory specialists, where it's all part of that system. The heart, the arteries, the veins. It's a system. It all works together. And if one part of it's broke, it affects it all. This is my favorite slide. And what I want to get from this is we all know those dabblers out there in cardiology or in peripheral arterial disease or what it is. We just do one thing and then nothing else. And in today's society, I think we all like that one-stop shopping. I can go to one place and I can find everything I need or know I'm going to be treated for it. So is your practice the destination to go to? I have leg pain. I don't know if it's vascular. I don't know if it's arterial. Maybe it's heart failure from all this swelling. Who do I go to? If I come to your practice, I know it's all going to be taken care of and addressed. It's a variety. You have dimension to your practice. So taking all of this information into account, kind of put together this circles of success, because I think when you develop a marketing plan or try to get a process going in your office, you need to have a direction of where you're going and have it mapped out. So this is kind of a blueprint that we used. So in the beginning, definitely need to start in your own backyard. You have to get your practice and everybody in your practice involved and knowledgeable about venous disease. And this doesn't include just your partners, but maybe your nurses, nurse practitioners, PAs, medical assistants, receptionists, the girls at the front desk that are handing out extra papers. Everybody needs to be involved in this and aware of it. Make the connection. Why are we treating veins again? Why are we doing this? Don't assume that they know. And this goes for your partners. Don't assume that they know the whole vascular system and what symptoms to look for with these patients. Because if I've been in practice for 30 years doing cardiology or just doing vascular surgery, and now I need to look at varicose veins and venous disease, you need to review all of that again. What is their current practice? What do they do with these patients now? Do they even address it? Do they refer them out to their primary care doctor like we used to do? What are they doing with them? Or do they just ignore it? And make it a mission of the practice. So that's part of your goal. Not only create this culture, but have a mission of what you want to do. You want to be a circulatory specialist, a vascular center of excellence, incorporating all of that. And gather that strength and support. You can't just be that one person holding up the rah-rah flag. You want to get everybody in on that. And then in your office staff, again, they're a conduit for your message. So when they're rooming those patients and the patient's asking, why do I have to take my socks and shoes off? That medical assistant isn't saying, I don't know, they just tell me to make you do it. Instead, they can say, well, because we're evaluating from head to toe to look at your circulatory system. So it's more educated, more professional. And when they get a piece of ownership, when you educate them, they feel like they have some ownership and a vested interest now in that vascular disease. And seeking a champion. In order to keep your process sustainable, the physicians I found are usually too busy to kind of stay on top of all the little nuances and evaluations that need to go on with this. So if you have a nurse practitioner, a PA, a medical assistant, an office manager, whoever it may be, that kind of runs and drives this program. And the best way that I found in educating the office and the office staff is we had like little in-services for breakfast or lunch or just talking to them. So who's in your waiting room? Are you seeing these patients with wounds? Do you have Summer Sanders in your waiting room? You know, they may not have those bulging varicose veins, but they may have venous claudication. And these patients are there. So the internal process, this is when we are now going into to find your patients that are in your waiting room and capturing them. And we know that they all, you know, what was their occupation? Were they nurses, teachers? They worked on an assembly line. Reaching out to these already high-risk patients that are sitting out in your waiting room, maybe coming in to see you already for something else. Take advantage of the educational opportunities in your office. By our treadmills for our stress test, we have information about, do your legs hurt? You know, they're on there, they're walking, they start to claudicate, swelling, putting education material in the exam rooms. That was always what I called my backdoor tactic, because I had some physicians that just didn't feel comfortable addressing venous disease. So we put up big posters in all the rooms. So then the patient said, I think I might have this. My legs look like that. So now it's the patient now talking about that and bringing it up. And it was interesting for a lot of the physicians to see that how many patients actually complain about this or can identify with vascular disease. Have takeaways also. You want pamphlets, you want brochures, you want even just a typewritten piece of paper so they can take that and say, I don't have this, but my neighbor has these complaints, or oh my gosh, this is totally my mom. I'm going to take this and I'm going to educate her. And now you may have just got a new patient from that. And established patients can bring those word of mouth referrals, and those are the best ones, right? Oh my gosh, you got to go see Dr. So-and-so, he's great. Don't let someone else treat your patients. This is the most embarrassing thing, right? You're this vascular center of excellence, you're treating varicose veins, and you find out you missed a patient who's been in your practice for 20 years. The primary care identified it and referred them to somebody else. So what we've done in our office, we have a process. It's been refined over the years many, many, many times, and getting everybody's feedback about how it worked and what would work best and how we can change it. This was pretty streamlined with the Dear Patient letter. They get this letter either at the front desk when they check in, or in our office we now moved it to when they actually come back to the room, because they were already getting too many papers at the front desk, and that was something that we changed through the girls at the front desk, the reception. That was their recommendation. So when they come in, of course they get their vital signs, go through their medications and everything, but then they're asked to remove their socks and shoes. We had to get little blue pads that they could put their feet on the floor. And then they fill out this Dear Patient letter, and I'll show you an example of that. And the physician reviews that. When they walk into the room, their legs are already exposed. So if they're coming in there for high blood pressure or atrial fibrillation or whatever it may be, but yet they have venous disease, but we never diagnosed it before, you can do it in just 3 minutes. Here were the questions that they answered from that Dear Patient letter. I can already look at their legs, ask them a couple more questions, and I've made my plan. Our patients are screened annually, so annually they'll get this form. Annually their socks and shoes are taken off, and then we send a letter to the primary care doctors, and that also serves as a conduit to educate that primary care. Just saw Mrs. Jones in the office today. She had some complaints of X, Y, and Z. This is our plan. We may reevaluate her for RFA, or we're going to do a venous reflux study, whatever it may be. Again, patient education, you can never have too much of that. So this is our form. This originally was just about PAD, and then as we morphed into providing more options and treatments for our patients with vascular disease, we added some of the more vascular questions on here too, or venous questions. So that first paragraph kind of talks about the circulatory system and why we're doing what we're doing, some general information about CVI and PAD. And then it goes through a few questions there about pain in their legs at night, heaviness, discomfort with walking, with standing at the end of the day. Does elevation help or does it hurt? So how they answer these quick questions can really clue us in to, do they have claudication? Is it arterial or is it venous? And then we also talk about some of the physical findings that they may have. Do they have swelling? Do they have cold feet? Do they have poor healing, itchiness? And then the risk factors, diabetes, smoking, and again, this is for PAD and venous disease, an occupation where you were standing, family histories. And we also use this form for the AAA screening for our Medicare patients. So personal or family history of AAA, and then smoking. So that form really has helped us streamline everything. It doesn't take much time with our patients to get them screened and to do that annually as well. And I would say 99% of our patients were happy and excited that we were actually screening everything on them. They didn't mind taking their socks and shoes off. A lot of our patients are very, very aware of the healthcare dollar these days. And if they feel like they're getting something for free, or, oh wow, you're really gonna do a good examination on me today, I'm getting everything checked, they appreciate that. So in your, moving on to the next source, your external referrals. So we've got our office, everybody's on the same page. We've got all of our internal patients engaged. Now going to that next circle where we have our external referrers. You need to lead by example, walk the talk. You know, you have the screening program and everything, and being knowledgeable on testing, because you are now putting yourself out there as an expert in this space. For somebody that doesn't know anything or very little about venous disease and what's new and happening, they're going to now come to you with the questions. Who do I screen? When should I send them? Do I just get a venous ultrasound? What is a reflux study? Where can I go to get that done? So educating those referring partners that you have, I always find that it's best to start with those that are already referring to you. They're already sending you cardiology patients. They're already sending you your PAD patients, whoever it may be. Start with them. One-on-one dinners or curbside consults. You know, you're passing each other in the hall and, hey, I saw Mrs. Smith today in my office, and this is, you know, what happened, what she complained of, or whatever it may be. Invite them to come and visit the lab and see a patient being done with the RFA, an open house. Network and go to the disease. So now maybe we're talking to OBGYNs. Now maybe we're talking to orthopedic physicians. Now we may be creating a new referral stream. Show the benefits of your service. Resource for the referring office, again, making sure that they know where they can get brochures and information like that. Communication, making sure that that door is swinging both ways. So when you do something, that you're getting that information back to them and knowing what their expectations are. After you get those external referrers, now you want to branch out more into the community with that community awareness. We have put on quite a few education seminars in our own office, and again, this drives word of mouth referrals. We even had some patients come that were not part of our practice at that point, but had seen a flyer or a friend had told them about it, so they came in to our office. Rethink varicose veins, again, a great, I like that we're rethinking it, because I think when we all went to school and you learn about veins and venous disease, it was about a 3-minute lecture, and now we have all this more information about it. And then screening and education events. So this is one of our physicians, Dr. Mo Harris, who did a talk, and we just labeled it, "Do Your Legs Limit You?" Very open, very vague, very subjective. You know, were these patients coming in for venous disease? Were they coming in for arterial disease? At this point, it didn't really matter. We were kind of covering all of that and giving them some information of where to go and what can be done. So in conclusion, being a center of excellence, that vascular center of excellence, it's not a destination, but it's a journey, and every journey starts with that first step. So also, and making sure you have a plan or a blueprint. You have your internal, start there, then branch out to your referring partners, and then out into the community. Implement a sustainable process. Again, that's key. And I think if you have a champion, or if you have somebody that is very passionate about what they're doing and what your mission is, they can help keep that flowing and going. Thank you.
Questions? All right, I think we're all done. Thanks. I just turned it on.
Can I ask you a question? Is there a code for
Yes.
There is a
Yes.
specific code.
Specific.
Okay.
Now, not everyone. Let me come down.
I'm still gonna drink that.
Hello, I'm Andrei Pop. I'm from Alexian Brothers. In the interest of time, I guess we'll be starting. I'm talking about essentials of venous anatomy and physiology, which sounds about as boring as it gets, but it's important stuff to know before you embark on burning various things in the leg. So let's see if this works. Okay. The remote doesn't really work. Give me a second to see if the remote works. Back.
We're going to take just a few minutes to set up the ultrasound, so we're not interrupting you. Can you wait just a second?
Yeah, you know, the thing is I have a talk at 1:20, so I have a talk. I have to kind of go on time. 1:24 on the arterial side.
All right. Well, go ahead and start then.
Okay.
And then I'm sorry that we're kind of...
No, that's okay.
Okay.
So let's start from the beginning. Hopefully the remote works. Part of what's actually quite important about anatomy is using the right nomenclature. And you see different reports from different offices, and everybody uses a different system. And it's actually very important to be consistent. The one place where it is super important is on the deep side, because a lot of people continue to reference the femoral vein as the superficial femoral vein, which, as you know, is very confusing for referring physicians, because you say there's a superficial vein thrombosis, they assume that that's a superficial thrombophlebitis, doesn't need Coumadin. So the correct nomenclature is the one that you see in this table, and they have a million veins that we don't care about. But the correct nomenclature is common femoral vein for obviously the common femoral vein for what used to be called the superficial femoral vein, deep femoral vein. Then you have the popliteal vein, and then you have the tibial veins, which are always multiples. There's at least 2 anterior tibials, at least 2 posterior tibials, at least 2 peroneals. And then you have the sural veins, which are soleal and gastrocnemian veins. And the soleal and gastrocnemian are quite important because I've seen several cases where people do sclerotherapy, patient comes in with a swollen, painful leg, and they go to the hospital, they get a DVT study. The standard DVT study in the hospital is looking at a popliteal and femoral vein, and they're told there's no problem. And if you pay attention to the calf, you'll find the clot in one of the smaller veins. On the venous side, you have the greater saphenous vein, obviously, the superficial epigastric vein, which is an important landmark when you're doing EVLT because you don't really want to go past it. And then you have the small saphenous vein, which is, again, new nomenclature. It's no longer the lesser saphenous vein. And we're going to go into some detail over this. So we'll start with a deep system. The essential points we touched on already. The superficial femoral vein should not be used. Inferior epigastric vein, I'll show you a picture. It's very important for greater saphenous ablation. What's important to remember that there's a tremendous amount of variability in the anatomy, which is something that we're not used to from the arterial side. On the arterial side, it's very rare that you see a major variant in anatomy, whereas on the venous side, it's almost the rule. So you can have 2 femoral veins, 3 femoral veins, you can have 2 which become 3, become 1. So there's a tremendous amount of variability, and it's important to recognize that. One ultrasound criterion is that usually the vein should be bigger than the artery it accompanies unless there's duplication. So if you have a femoral vein that's the same size as the femoral artery or smaller, suspect duplication and you may be missing a DVT. And I've seen this numerous times. People are told that they didn't have a DVT, that then the DVT showed up, and it is because of duplications many times. This is from an article that shows the range of variations. As you can see, the popliteal vein can be formed at various levels below the knee, above the knee, can be duplicated. And you can see the venograms on your left side, on the right side of the screen. We don't do as many venograms as we used to. We do them mainly for DVTs, but it's important to be cognizant of the anatomy. This is the best picture that I could find of a duplicated femoral vein. You basically see that the vein is actually smaller than the artery, and one of the veins collapses, the other one doesn't. So on the left-hand side, it shows you flow in the lumen that's patent. On the right-hand side, you don't have flow, and actually you're picking the flow from the artery. So this is crucial to recognize when you have a duplication, because otherwise you'll miss a DVT. The calf anatomy, this is a quite complex slide, but basically what you want to be aware of where the veins are, and you see the greater saphenous vein, and at the bottom you see the small saphenous vein with the sural nerve. And very importantly, you want to be aware of where the nerves are, because people have done phlebectomies and they've come out with pieces of nerve, and then you're wondering why the patient doesn't have sensation in their legs. Or you can go down and burn the peroneal nerve, which is kind of frowned upon, because then patients get foot drop and all sorts of other bad things. So anatomy is quite important. This is a schematic which shows you basically the deep system. You see the soleal veins at the back, you see the anterior tibials, posterior tibials, and the gastrocnemian vein right at the level of the knee. So how come we care about deep calf veins? You know, my hospital doesn't look for them, a lot of hospitals don't look for them, they don't care. Well, 15 to 25% of calf DVTs extend proximal within 1 week. If there is no extension within 2 weeks, the risk of progression is slow. So the most recent ACCP guidelines talk about this and give you criteria for how to treat a calf vein DVT. As I said, it can be a source of pain after DVT and people don't pay attention to it. According to the ACP, the most recent ACP guidelines from last year, you don't need to anticoagulate these people if there's few symptoms, there's no risk factors for extension, and if you don't anticoagulate them, you need to use serial imaging for 2 weeks. If anticoagulation is indicated, you use the same protocol as for a proximal DVT. Yesterday, I saw an add-on in my clinic. A young lady had a cast, smoker, birth control pills. 2 weeks after the cast comes off, she has a swollen, tender calf, goes to the ER. They tell her she's got a superficial thrombophlebitis of the lesser saphenous vein, comes to see me 2 days later because it's hurting much more and it's much more swollen. And we took her over to ultrasound, and lo and behold, the clot had extended to the popliteal vein. So we put her on Xarelto right away. We got her, some compression, and she's hopefully doing fine. But it's an example of why you have to pay attention when you're looking for DVTs to the superficial system as well. These are the risk factors recognized for proximal extension of calf DVTs. If you have a positive D-dimer, if the clot is greater than 5 centimeters, closer than 5 centimeters to the junction, clot involving multiple veins, vein diameter greater than 7 millimeters, unprovoked DVT, active cancer, history of PE, or inpatient status. These are the people who are most likely to progress from a calf DVT to a popliteal and higher DVT. If you see any degree of extension of the clot, those people need to be treated. You don't want to see them reach the popliteal before you treat them. One thing that I don't know if people are going to touch upon is there's been talk recently of accessing the pedal veins for using DVT work. I've done a few of these cases. The posterior tibial is generally the better target. The nice thing about it is they're generally engorged when the popliteal is clotted. The problem is that although they're engorged, they're small. There's usually 2 or 3 of them for each blood vessel. And you really need to be careful about spasm. I've had probably the worst vasospasm in my career in a posterior tibial vein with a 5 French sheath, and it took about an hour to get the sheath out after giving a boatload of nitro and nicardipine and anything you can think of. So usually when I get access in a pedal artery, I just push the wire up under fluoro visualization without necessarily taking a million pictures until I get to the point where I know the occlusion is. However, here, it's really useful to take some pictures, see where the bigger veins are, and try to kind of follow those paths, because there's really a plexus of veins in the calf generally, and you can easily get stuck. Superficial veins, we talked about the lesser saphenous being dead. The other important thing, the greater and small saphenous vein are inside the fascia. They can come out of the fascia and go back in, but generally they stay inside the fascia. In terms of accessory veins, if they are parallel to the greater saphenous and outside the fascia, they're called anterior, posterior, and superficial accessory. If they go at an angle, then they're anterior and posterior thigh circumflex. And there's a bunch of other denominations that you can use, but these are enough in my book. This is a schematic showing you the tract of various accessories. As you can see, the anterior, posterior accessory are parallel to the vein, and the circumflexes are at an angle. This is an example by ultrasound. The star is the greater saphenous vein, and then you have the anterior accessory at the top, the superficial accessory, and then you have at the bottom you have a small saphenous vein with a intergemellar vein which goes next to it. So you need to be aware of accessories veins being there outside the fascia. This is the degree of variability that you have for the saphenopopliteal junction. You can have anywhere from no connection to a lot of connection to a small connection. I use this a lot for my DVT work. Rather than sticking the popliteal, I stick the small saphenous, and if there's a direct communication, I just take that out. It's very nice because it's very superficial, easy to compress, and if you don't get it, you can go for the popliteal later. Saphenofemoral junction, the only point I'll make here is the inferior epigastric vein that you can see on the right side of the screen, that you don't really want to go past that with your ablation catheter because you're going to end up with the common femoral thrombophlebitis, DVT. Really quickly, there's a couple of nerves that are in the area and you want to be aware of. The sural nerve accompanies the small saphenous vein superficially in the calf. It's a purely sensory nerve. The saphenous nerve, largest cutaneous branch of the femoral nerve, accompanies the greater saphenous vein, purely sensory again. This is why you want to keep away from the distal part of the calf when you're treating things. These are the distributions of the nerves. We're not going to belabor this. These are the areas where if you burn too much in the greater saphenous, this is where generally patients get either hyperesthesia or anesthesia. So these are the two areas where you want to pay attention. The peroneal nerve comes out in the popliteal fossa. It can be damaged by laser or EVL or venous when you're doing a small saphenous vein. You want to be careful, especially if the small saphenous vein connects high up in the popliteal. This can lead to motor deficit, which is generally a big deal. You can visualize it on ultrasound, but you get extra points for doing that. It's not always that easy. Perforators, I generally don't go by all this crazy nomenclature and named perforators. I describe where they are, what they connect to, and that's about it. That's enough for me, how big they are, how much they reflux. You have to be able to recognize proximal occlusion or compression of the vein from the ultrasound waveforms, fluid overloaded status. I'm not going to belabor this. This is essential ultrasound stuff that's often missed on inpatient reports. And that's it. Questions? Thank you.
Thank you, Dr. Pao.
Thank you.
All right. Thank you, Dr. Pao. That was a very nice presentation. We have now live ultrasound imaging with Dr. Thorpe leading that session. Did you need a microphone? Sure.
I don't know if we are going to hook up the imaging from the ultrasound to the screens, but we're going to be examining two patients down here. Dr. Ossie has volunteered for what he hopes is normal vessels because we wanted to show normal, deep, and superficial veins. And then Phil has volunteered to allow his saphenous veins, which are quite refluxing, and we'll be able to see his stents in his deep venous system, see if there's any deep reflux below that. And Vicki Janowski is the RVT who works with Dr. Jaffer, and she's here today to volunteer her efforts at doing the exam. So I think we're going to start with Dr. Ossie. I can emphasize how important it is when you're looking for reflux to do a standing exam. With a lot of reflux, of course, you can see it when a patient is supine, but if you're looking for somebody who's symptomatic and you don't see it in the supine position, it's really important to stand the patient up. And also, interestingly enough, reflux gets worse during the course of the day. People who are negative for reflux in the morning, if you examine them later in the day, oftentimes they're positive. So,
Can I make a comment?
Yes.
Actually, all my patients who are going to have an ultrasound, I tell them not to wear the stocking that day, to stand outside for at least an hour.
stand outside.
No kidding, because we've seen that, and then also that they should be well hydrated. And
Well hydrated in order to document. People who are coming in for documentation of saphenous reflux because they have visible varicosities that they want ablated, we need the documentation of the size of the vein. And someone who comes from working out can be dehydrated and their veins will actually be small and non-refluxing, even though they have varicosities that bother them. Are you able to hook up, Vicki?
sure, and I can do my presentation if you want. All right, yeah.
Okay. We're going to switch the order just to, in the interest of time, and Dr. Chopra is going to give his next presentation. Give them some time to get this all set up.
So, when Pat first gave me the topic, she said stockings or intervention. And I belabored over it for a while, and I said, it's not either or, it's both. And so last year when I first did it, I kind of made it more into a how to clinically evaluate a patient and the logic behind it. And but in the last year or so, I've paid a lot more attention to the venous pump and the physiology and how it makes a difference, because I think it's extremely important to have patients ambulatory, walking, and how the calf pump works makes a tremendous difference. I have some very nice pictures that I found. It's amazing what you can do on Google these days. You write, just Google something, pop, it comes right up. You know, all the scholarly work has disappeared, I guess. So what I'm going to focus on is how do you go ahead and evaluate a patient in the office setting for something like this, but tying into what are the treatment options and whether only compression is good or just intervention. And as I said, it's not either or. Now, superficial venous disease is definitely not uncommon, is definitely not benign, and everybody wants healthy, strong legs, and to want beautiful legs, but beauty implies this underlying health. It's very common, a lot of that goes on, and as I mentioned in my talk earlier, I have not yet met one person who says, I don't want beautiful legs. So in terms of evaluating, take a detailed history, we take detailed pictures, very important, standing ultrasound, mapping the appropriate benches, because the bottom line is all of these effects are the effects of venous hypertension. The venous hypertension comes from venous insufficiency, and you've got to find the source of the insufficiency, the source of the hypertension, and now find a way to negate that. That's where compression comes in. It's very simple, and get the flow going. If blood's not flowing in a vein, it's got problems. So, and a lot of patients have been told, yeah, it's okay, just some varicose veins. Even doctors. I've had the chief of anesthesia at one of my hospitals walking around, and he had some phlebitis as well. So when I explained to him, I'd given a talk that how your incidence of DVT goes up. He read about it. There are enough articles on that, came in, and we've treated him. Pictures absolutely essential. You look at it whether you have telangiectasias, venulectasias, reticular veins. Now, the reason I'm quickly going through this as a background is, as you look at it, the reflux starts from some level, whether it's a saphenofemoral junction, a perforator, but it comes from the deep to the superficial. And then it's really like a river all the way out to the final tributaries. The other example I give the patients is whether you're dealing with leaves on a pond, lotus leaves, you have to get to the roots. And all these changes from the hypertension are then manifested out. So how do you counter the hypertension? One caveat is you examine from the bottom up and you treat from the top bottom. It's important to understand where the flow is, because this ties into where you're going to intervene. I see folks puncturing the saphenous at the ankle, putting a long fiber all the way up when only the top 2 centimeters of the saphenous was incompetent. And that's where everything's coming from. There's no reason to burn the entire thing out. So it was really to create a map of the hypertension, find out what is leaking, get to the source. And the same goes with the compression as well, and also an understanding of how the pressure works. You'll see an example of ultrasound, but ultrasound is really getting under the skin to look at what's going on. Very, very important to counsel the patient, get them into a discussion. They need to know the goal of that treatment. If it's a wound, why did they get the wound? How do you going to heal the wound? But you gotta get the underlying venous hypertension and leaking from the veins stop. And they have to have compression therapy going on at the same time. We discussed, and you want to talk about the cost of compression therapy, cost of intervention, the timeline of intervention, and also long-term follow-up. It's not just a one-time thing. So this is something I want to focus on. Not a lot of people talk about it. We know it exists. But there really is a pump in your legs called the venous pump. And there are really 3 factors to it. And something I've learned in the last year a lot more is there's also a plantar pump, where actually your walking motion empties out the plantar fascia. So there are 3 steps really. The proximal calf has a pump that's as the muscle squeezes, and your foot is kind of plantar flexed. When you dorsiflex it, then the anterior compartment veins empty out, and then there is a plantar aspect as well. So it's important that these patients are ambulating well, not in stiff shoes. I learned this from runners and podiatrists. They're Mexican runners or down South America who run bare feet, 3 marathons at a time. So there's this entire movement about doing the right movement of your legs. It empties out the plantar pump, empties out your calf pump, the dorsal and the distal, and kind of the lower pump is more like a piston pushing the blood up. And this, I wish I could point here, but in normal healthy leg, what happens? So when you're just laying down, the pressure is 0, and I have a picture to show you that, but there's and when you're standing, the pressure is from the heart to the ankle. So 2 individuals of the exact same height, doesn't matter, they have the same pressure in their veins. That's just how it works. And so it's around 100 in a healthy individual. And when you're standing, the pressure goes up, the flow is close to 0 on the top. When you start walking and you start using your muscles, the flow changes. But while walking, during exercise, the pressure in your veins needs to drop down to the ambulatory venous pressure, which is around 20 to 30. That is why the 20 to 30 stockings are important. If you're laying down, the pressure in your veins, its superficial veins, are 0. So if you see the graph as it's going down, the green line and the red line, the green line on the pressure curve, as it gets through and you're walking, before you stop during exercise, the pressure needs to come to that line that says AVP normal. Okay, and if you look at the diagram that shows you the deep veins, blood's going up. From the superficial veins, all the arrows show blood going up. Perforators, all the blood going into the deep. That's what the normal healthy leg should be like. When the pressure in your legs does not come down when you're exercising your calves, that is when you have venous hypertension and the pressure in your deep system goes up. That pressure has to reflect somewhere. That pressure reflects out. And that, when you saw the first anatomy slides, that pressure now has to transmit somewhere, so it finds its way out first through a large vein, a reticular vein, a telangiectasia, and comes out. So I've seen people do vein waves. I did that earlier in sclerotherapy, but if there's a big reticular and perf feeding it, till you take care of that, the telangiectasias are going to come back. This is another slide showing the same thing, but a little more graphically. And you see when you're laying down, pressure 0. As you start to rise, the pressure goes up. Now, as I'm standing, average of 5 feet heart to ankle, my pressure in my deep system should be 100. As I move my calf and pump it up, as I exercise, that pressure in a normal vein should go down in a healthy limb. In an unhealthy limb, that pressure does not go down because of the reflux, which I'm going to show you in a second. So the key principle here is that the calf muscle pump kind of regulates the venous pressure. And here you see what happens in a unhealthy way, there's reflux. And this also, as John was talking earlier, Dr. Golden was talking earlier about how reflux happens in the deep system and goes away when you take care of the superficial system. This is something that not many people put into their clinical practice in terms of thinking, but this is where it becomes important. This is what translates to the effect. So if you have venous thrombosis on the top and venous occlusion, the pressure is always high. Normal, healthy individual, when they walk, the pressure drops. If you have superficial insufficiency, it does not drop, it's still high. But if you also have deep, it gets even higher. And you see the effects of that pressure. So now when you start treating it, you want to use compression to squeeze that out enough to counter. Obviously, if you have somebody with venous obstruction or deep, where the pressure is higher, you need higher compression stockings. If you have somebody with mild reflux, mild hypertension, you can get away with 15 to 20, but otherwise, the reason 20 to 30 is considered the baseline for compression for treatment is that because the ambulatory venous pressure is 20 to 30. Anything less doesn't make a difference. They may feel a little better, or you may get a little compression on the side. So bottom line is, and then for the interventions, is I know there's a reflux from this perforator. So as John showed that slide earlier of the lady with the eczema, the wound care centers in my area send me 100% of their patients. They will not treat a patient until I've seen them for both arterial and venous. And I've ablated perforators in the ankle, you name it. There was one patient where I did 17 procedures. But we took him from a limb where he was begging for amputation to a normal, healthy limb. But the concept was first compression. Then, as we started working top to bottom, took care of the saphenofemoral junction, started working our way down till we started getting him closer and closer to normal pressure. So now he's weighing 20 to 30 and doing good. So that's kind of the progress, so to speak. In terms of other compression devices, something I found very useful is this home compression. There are many companies that do this. Medicare covers it. For extensive edema, they sit at home, they got the sequential pump, and I've had patients with massive legs come down to normal enough where they can ambulate better. When they ambulate better, and that's why, they get put in these stiff shoes, I tell them, see if you can get out of those shoes. So I spend a lot of times talking about stockings, I talk a lot about what kind of shoes they are wearing, et cetera, to help them do that. And then I will intervene if conservative therapy takes care of their goal, which is, relief of pain. You got them stockings, their pain's gone, treatment's good. We'll keep them, watch them. But I start intervening when their goals are not met, but I never stop conservative therapy. And the conservative therapy, which is compression, continues during treatment, but I advise them to wear it for life. I wear it for life now. There's so many, all the athletes wear them. They have different kinds of compression, and an important factor is you don't need pantyhose. You don't need all the way up to your thigh. 50% of the gradient from the ankle stops at the knee, by which I mean if you got 30 millimeters at the ankle, it's 15 at the knee already. So you've squished it out of the calf, so the patient must at least have a calf. And some folks, they're obese, or they don't like it, they have knee problems, and you give them a kind of a tough stocking to wear, they won't wear it. And then the compliance falls, your interventions fail. So they kind of go hand in hand, and that's at least the logic that I use behind it. So good clinical evaluation, get the goals of therapy, establish what is it you're going to do, create a plan, then find out where's the pressure coming from, compression therapy to start pushing the pressure back, then start shutting off the spigots. That's how I do it. That's how I explain it to the patients and work our way through that. So, thank you. I guess time for the ultrasound. Yes? How do you get compliance? Here's one thing. Like I was saying earlier, I've never met a woman who doesn't want her legs to look good. So I have a catalog of all the different ones. And I have samples of all the different stockings. So the TED hose, the anti-embolic stockings, they're horrible. I make them feel that, and they kind of look at me and growl. Then I show them the very fancy one. There are many that make it. Sigvaris makes one, and they go, wow. And there's this very nice, sexy-looking woman up there who's got it. They've got sports stuff. I spend the time. And I tell them, sweetheart, I'm going to take care of you. I want your legs to be beautiful. And I show them a picture of how it could be. Or I tell them, get a picture of how you've had it before and how you want it to be. And I said, for you to get here from here to here, you got to help me. So I need you to walk. I need you to ambulate. And I need your compressions. I spend that time with them. And I tell them, you will do better. And I have patients, they'll be sitting in the hallway, and if they don't have their stockings, I tell them, it's pointless me treating you, so let's get on with this program. So I measure them, my staff measures them, 100% compliance.
Everybody in our office wears them.
Me too. I show them. My staff shows them.
Show the patients. The other thing is we have mock-ups for the donning devices, and there's a device now to remove them, getting them around the heel, taking them off is a major complaint with patients.
Yes. And it doesn't have to be only the stockings or the socks. You can do Circade. You can do the other pumps. I've had a lady whose leg was so big, and we did custom. It was several $100s, and then it was a waste. So I got her on that sequential pump. We've worked with some companies who give them that service, and they know I care. So if I care, they better care, and you get compliance. If you just write a script and tell them to go, it's the worst thing you do for them and for yourself. I guess we'll get to the ultrasound.
I want to ask you a rhetorical question while we get set up here. The white TED hose they put on people in the hospital, I think, to me, they're useless when you're walking because the pressure is not significant for compression for people who have venous disease. I think we do people a disservice by making them, so many of them think that that's the compression stocking they need.
Especially nurses.
Yeah,
So actually, if you dig deeper into wound care and talk about compression therapy, when you look at the Una boot, there's stiff or inelastic dressings, and people even measure the stiffness index, and there's elastic. So the elastic ones, which we talk about, which for non-ulcers that we use, are shaped to the leg, while if you look at the Una boots and the tight wrapping, those are much higher pressure, much stiffer. There's a lot of debate going in there, but the TED hose and the ones that are tight for walking do not allow the ambulation, number one, and do not get them back to normal flow is what I've seen. And the compliance is very low because, and the other thing is very important, I've had patients who are friends and in social circles, when they wear that stuff, they feel they are sick. When you give them something fancy and it's got knitting and all this stuff, and because in the Christmas event, one of my neighbors, she's my patient, and somebody started, oh my God, what happened to you? And blah, blah, blah. So I said, get back into my office, and we showed her these, and she got those, and her entire perspective on this changed.
Good.
All right.
Thank you.
Thank you.
Thank you very much. Now, Vicki Janowski is going to start. We'll be projecting up there. Is it working now? Oh, good. And he's going to try to do an inset of her technique. So you can see where the probe is, and she's going to also, are you mic'd up, Vicki? Oh, okay.
Am I loud enough to hear?
Sure, I think so.
I see there's ultrasound on one and image on the other.
You can see the beauty of a portable ultrasound machine. The technology is really incredibly good now.
Put the patient to work. Which ultrasound machine is that?
This is a MedPro by GE.
It's a GE. So this is his right femoral vein, and you see the femoral artery above it.
So kudos to her for not saying superficial femoral vein.
We'll augment it. Perfect. Traveling down the thigh, we're going to the mid-thigh femoral vein. Looks Then we'll move down, we'll go to the popliteal vein, which is behind the knee.
just the ultrasound everywhere?
Augment of the popliteal vein. This is pretty normal flow he's got going here. You did good. Okay. Do you want to get... Distal popliteal vein. Go ahead. Okay. That's a good tip to use when people don't like to get their legs squeezed. Because there are some patients that it's painful for.
The normal velocity in a popliteal vein is about 9 to 10 centimeters per second. And if there's a stenosis, it'll go higher. If there's no flow in the femoral, of course, it'll be non-phasic. And we're always looking for the waveform in terms of its phasicity. And we record all of the velocities in our lab. But a lot of people haven't paid much attention to that, but particularly whether or not it's phasic is a clue to whether or not you have some proximal obstruction. Because if you're only working with saphenous veins, or how do I say, examining people to clear them for an ablation procedure, you have to be very careful that you don't miss some proximal obstruction that could be very chronic. Because if you do an ablation and they have a May-Thurner compression or an old DVT in their iliac, which they didn't tell you about because it happened 20 years ago when they had their first baby or something, then you're going to run into problems after you do a saphenous ablation. Yeah, would you want to show the posterior tibial? Now, you know, a lot of people who do venous, start doing venous disease have a little bit of difficulty getting their techs trained in how to do veins. And Vicky's going to show you how well you can visualize posterior tibial veins in a patient. Now, of course, when there's a lot of edema, it makes it more difficult. But the techs can be trained to know exactly where to look. And like Dr. Hunter was alluding to this morning, we examine the tibials, which are what? Perineals and the tibials, 6 veins we're looking for. But there are 100 miles of veins in your calf, maybe more than 100 miles. And Dr. Strandis always used to teach that there are 100 valves below the knee. And there are probably 5 to 7 valves between the popliteal and the groin area. So, you know, there's a reason why there are 100 valves below the knee. It's to help propel that flow effectively through the calf into the popliteal system when the pump action works when you're walking. So we want to protect those valves, and calf vein DVT is not trivial. You can have open veins up above and completely occluded calf veins, and you'll be very symptomatic. So what are you looking at here now? The popliteal, mid-calf. Posterior tibials and longitudinal, those are horizontal. So you can always find the artery and the 2 veins to the side in a normal individual.
Sometimes they run a lot deeper than you expect.
Right, there can be some variation here. Okay, so shall we shift to, anybody have any question about normal appearance, no reflux that you saw. So we can't demonstrate reflux yet. Dr. Osborne's happy about that because he volunteered here and he's traveled a lot. And no DVT so far, limited exam. Well, of course, one of my pet peeves is that people don't look above the inguinal ligament when they're examining people, and that happens to involve 2 requests and 2 CPT codes. But a complete exam of the lower extremity does involve looking at the iliacs and looking at the tibials. So the CPT code 93975 will be in your iliacs, but 93970 or 71 will be your lower extremities, which can include from your common femoral to your toes. And that's where they should be examining. So Phil is going to come up, and he has volunteered to let us demonstrate significant reflux. And Phil has had varicose veins since he was younger. And I do believe that when you see varicose veins in a young individual, particularly a teenager, it's a red flag for a central venous obstruction, usually a caval obstruction. Most commonly an infrarenal caval obstruction that will be either from having a central line when they were a kid, an infant, or from trauma. And invariably when I've seen varicose veins in a teenager, they have an IVC problem. And I believe that your varicose veins showed up when you were pretty young. Yeah, 16, you see. So he had an indication that he had a central venous obstruction long before he developed a deep vein thrombosis. And that's usually the case. They'll present with an acute DVT, but then the history will show you that, you know, there was something going on way before. But varicose veins in teenagers aren't normal. They're an indication of obstructive pathology. So now that he has patent stents, the question is, can he have the saphenous ablation and remove the refluxing saphenous veins? The consensus is yes, that would be okay. And when we first started stenting people, we were all reluctant to, you know, do anything to the saphenous system before we understood how long-term the patency would remain in the stents. But now he's been 15 years with patent stents, despite some redilatation for some stenosis, but never has had another thrombosis in the stent system. So after 15 years of patency, we feel that it's okay for him to undergo the saphenous procedure. I'll let you talk, Vicki. Oh, that was a stent. Here, you can see the stent. These are wall stents. Nitinol stents don't show up very well most of the time. And covered stents don't show up very well either sometimes, but these wall stents are very visible with ultrasound. Look, see how patent your stents are? Doesn't that make you feel good? So it's phasic, which indicates that his proximal stents in the iliac and the IVC are patent because the phasicity emanates from the heart. Phil, those are absolutely beautiful. I'm glad to see him. I hope you are.
So now we're heading towards the proximal femoral vein. Still stented.
Now, sometimes when the technologist has a little bit of angulation on the transducer, you can get some edge echogenicity, and you have to try to figure out whether there's an actual, is that near the inguinal ligament right there?
Yes.
See that the stents actually narrow right by the inguinal ligament?
Right there.
Right there, and there could be some intimal hyperplasia. What we found is where their stents overlapped in that area, intimal hyperplasia does occur over time, which can be treated with angioplasty. See, I think there's a little bit of thickening again along the wall, but then course, you do a different image and you see a complete flow.
Proximal
That looks
femoral.
pretty good, yeah. It's spontaneous flow. Do you want me to try to augment for you? Here, I'll do that for you. You can see very good augmentation coming through from a calf squeeze.
Just traveling down the thigh.
So there, I think the flow is trickier to show here, but it's still spontaneous.
There it is. Okay, let's head to the popliteal. Let's see his popliteal.
Does anybody have a question? Okay. Now we could probably demonstrate some reflux here. Wasn't too much, was it?
Not too much.
But we'll examine you standing up too,
Standing up, or at
okay?
least to have his leg dangling, yeah.
So when she squeezes, we're looking for flow to come above the line and for how long it persists above the line. And in a supine position, we're not able to demonstrate too much, but I think that we'll stand him up and we'll see, or have you put your leg over the
Dangle
edge.
your leg over the
Just
side.
dangle your leg over the side there.
Just keep it relaxed for me.
Now, mind you, she's looking in the deep system too. We haven't looked specifically at the saphenous vein, have you?
Not yet.
No.
I can see the valve in there.
So it actually is looking like there's a small amount of deep reflux, but I think most of his reflux is in his saphenous system.
I will do that, yes.
You can see that bulbar area there. Here's his saphenous vein, which is quite large. See, it's within that fascial plane. There's the fascial above and below.
This is his proximal thigh.
This is proximal thigh. We're a very large saphenous vein. Probably measures more than 10 for sure.
Just at 10.
Just at 10.
Dr. Golan, you have a question?
Yes.
Dr. Thorpe, I have a question for you.
Sure.
You have a teenager with varicose veins. What kind of evaluation do you do other than
I'm sorry.
how do you evaluate?
Okay, okay.
Like an MRV, CTV, I would do ultrasound, looking for loss of phasic flow in the iliac veins.
So if you have phasic flow in the femoral veins,
Doesn't, yeah,
sufficient for you to
no.
study, or do you routinely do MRVs?
Well, you can get phasic flow in the femoral vein because you have a long-standing hypogastric collateral system. So your iliac can be totally occluded, and your distal cava can be totally occluded, and you'll still get somewhat normal appearing flow in your common femoral. So if you're still suspicious and that looks normal and not abnormal, I would get an MRV. Or now in our hospital, too, we've got pretty good CTV
Yeah. So
with
similar,
three-dimensional reconstruction.
just to substantiate that, lady was treating for ulcer not too bad, but just kept going on and on, 3 years out now after starting treatment. So a deep looked normal, phasicity was fine. Then I said, let me examine, kind of above the legs, and I saw a massive collateral going right across her pelvis.
Pubic area.
And then, so we got a CT, just a plain simple CT, and saw that iliac looked occluded. I brought her back, did the venogram, opened the iliac, and with history, 22 years ago, she had some intervention and a DVT. She was on Coumadin chronically for a while and then went off. So you're right, something like that, even with phasicity, may not necessarily indicate that there is an occlusion.
If you have an obstruction of your external iliac and your common iliac, you're generally going to get non-phasic flow in your common femoral. But when that hypogastric system is open to a very large ovarian system or testicular vein and collaterals, then you can still get transmission of the cardiac waveform.
Just regular CT.
Regular CT. At Arizona Heart, they've developed a way to do a pedal infusion of contrast for the CTVs, which is giving spectacular images. Of course, it's invasive, and it's, but it does a better job than when you just inject it in the arm. Leg pain. Well, I've had occasion to get a number of those approvals, and we just say they're leg pain and vein compression. We think that the 429.2 vein compression code is a very powerful code for getting authorization for venous problems. If you just put varicose veins or swelling, it's not very compelling.
And you can ask for a peer-to-peer review if once they deny it, and you explain to them, I'm looking for iliac vein occlusion. The procedures are way more invasive. If it's normal CT, they save money. They respond to that.
So this is his greater saphenous right above the knee. We're going to go ahead and I'm going to squeeze.
Oh, now see,
the
that's an
reflux there?
incredible
It's some serious-
example of reflux. And you can see when he's standing with this very large varicose vein, the spontaneous flow is almost down to zero. When you're looking at the velocity there with no augmentation, right at this level. Can you do that one more
again?
time for us? Yeah. And she's putting the cursor on there, and we'll see what kind of flow form. Just see, it's really almost a zero, isn't it? Until he compresses his muscles, or she does augmentation.
It's very low.
Very low flow through those
Go ahead.
big saphenous veins. That's why it hurts their legs.
There's the reflux.
It's a tremendous reflux. I mean, that's grade 7 reflux.
Could you check his deep too? It'll be possible that there's recirculation in his deep reflux as well, at least part of it.
I recommend if anyone is starting to do venous work, to just have your technologist go to a place where they do a lot of venous work and spend a day. Sometimes the companies will bring in an expert person to help, get them more familiar with what you're supposed to be looking for and a routine. But it really helps to have them just spend a day with someone who can they'll learn very quickly. But a venous ultrasound, to my observation, is not taught very well in ultrasound schools. So they can come out of those schools knowing how to look at carotids and arteries, but not veins very well.
This is his proximal femoral. I'm going to go ahead and augment. And there's some reflux there.
Right,
There you
that's
go.
the deep system. Here's the reflux.
Especially if you find a perforator, and you'll see there's recirculation through the perforator, especially when he stands up, and you'll find reflux in that segment.
And there's your reflux in the femoral.
Another good trick is to get your tech to actually follow through when you do the procedure and you see the results, so they know they said there was reflux here and what happened at treatment, and you tie the dots together.
Now
You get
she's-
better each time.
She has the cursor in the stent
In the
itself.
stent. This is the mid-femoral. We'll go ahead and augment. Not too much.
I don't see too much. You know, the argument in the very beginning of stenting was, well, it's going to like eliminate the valves because, of course, you're stenting the outside. But the problem is that obstructed veins don't have good valves anyway. They're not in play, and after a month or so, the valves usually don't recover very well. So it's better to have an open vein. And as you can see here, within the stents themselves, there's relatively little reflux. And below that, as soon as you open up the obstruction, you stop the progressive damage of the valves below because there's not as much pressure once the obstruction is open. Then there are probably other factors that play. But I have patients in whom I have stented open their iliofemorals, and they have no reflux, absolutely no reflux. And they were obstructed for 3, 4, 5 months before they were treated. So there's a lot we don't know about valve resiliency. I believe some people do recover, or they certainly don't deteriorate once you open up the obstruction.
This is his popliteal vein. Shows
So
a
there's
little
some
bit-
reflux right here, a little bit of reflux. Well, I think we need to move on to the next discussion. Vicki, thank you very much.
Thank you.
And Phil, thank you very much. And Dr. Ossie, thank you very much for volunteering. It was very helpful. And audiovisual people too, thank you.
Great.
Okay, we're going to move to a
panel discussion.
which is an informal discussion open for some questions from those who have experience with this. Dr. Dipple and Dr. Golan are going to come to the podium, and we're just going to have some questions about, both of them have experience with different types of ablation procedures, and patients who come into the office have heard by advertisement and seen in magazines that there's laser available and radiofrequency available and foam available. And we just like to ask our panel of experts here how they might determine, other than what they have in their office, how they can advise patients, or what is there a controversy or not? Is there unnecessary competition here? Is this a trumped up controversy? What do you think?
We'll let John go first, or Dipple. You can fight it out. Okay, we'll let Dr. Dipple go first.
This is Dr. Dipple from Davenport, an interventional cardiologist from Davenport, Iowa.
Yeah, I think, my background and training is in interventional cardiology, so I'm not sure what the audience's background is, but one of the things that kind of struck me when I got into this that's a little different from the peripheral arterial side of things is that most of the things we do in peripheral arterial work are off-label. And so it's actually very difficult to get any kind of training or anything from any of the industry, because the stents, for example, are indicated for biliary use, but they're not indicated to put in a femoral artery. And so just learning how to put in a femoral stent is, you kind of have to go through the back door and find somebody to show you, basically. But in the venous world, all this stuff is labeled indication. It's a completely different arena. So the industry is extremely helpful in kind of holding your hand and taking you through things and showing you how to do it, showing you how the anatomy is, getting your ultrasound techs trained. And so that's one thing to me that's if you're just starting out, it's maybe not necessarily which system you go with, system A or system B or whatever, but just finding some support from the industry or somebody that can really send you to some courses, get you in front of some preceptors, have somebody come into your lab, into your office, and kind of get you going. And that's one thing that I found very helpful just from the very beginning.
Well, the great news is that it all works.
whether you use radio frequency or laser vein ablation. It's all very effective and it all works, and you have to kind of tailor which technology you think is suitable for your area. I use a laser exclusively. I have for the past 10 years. And interestingly, while patients are educated, I have never in 10 years had a patient come into my office and ask me why I use the laser as opposed to radio frequency. As educated as patients are, they really just don't know the difference. I've had a couple ask me what type of laser I use. Do I use a cool touch laser? Do I use a different kind of laser? I think in the beginning, the advantage of laser over radio frequency was duration of treatment. With radio frequency, before they came out with a closure, with Venefit, before they came out with their new closure catheter, it took about 40 to 45 minutes to treat a 40 centimeter segment of saphenous vein, whereas with the laser you could treat that segment in 2 to 3 minutes. Now with the new closure fast catheter, the treatment times are fairly similar with both, and if anything, it might actually be a little bit quicker with the closure fast catheter than with the new 1470 higher wavelength lasers.
I'll add a couple of things to this. I first started in Chicago. I think was one of the first to do this. I did only RF, then I did only laser, and now I do both. And one thing that we don't like to talk about in meetings, but this is a business that we all are in, and socioeconomic and economic factors play huge. So if you don't get approval for RF and you get it for laser, what do? You still you figure it out. So we have enough patients for, don't ask me why, that some insurance companies will approve one and not the other. Some approve for both. But I agree with John, not a single patient has come to me and said, I only want laser, I only want RF. It's, they don't have that knowledge with that. And then, but recently I found the reason I switched from RF away was I had to do the saline infusion and all that stuff, and it was pain, and the laser was faster. Now actually there's some safety when I had some new partners join me with the closure fast. Now there's, you can't just heat anything. It's got to be in there. Impedance goes up, it stops. If you're doing a perf with the laser, you can keep burning away till God knows what can happen, which you can't do with the RF system. So there are pros and cons, and each company does a little back and forth. But in your world, it'll be your support, as you said earlier. It'll be what your reimbursements are, what approvals you're getting, and you'll go with that.
I would add, I think it's difficult for me. I use a laser exclusively, and I've talked to the Venefit people. But I practice in a fairly small area on the North Shore of Chicago. A lot of my patients know each other. And to try to explain to one why I decided to use technology A and to explain to another why I use technology B, if I have two patients meet at a cocktail party and one had an unpleasant experience and the other had a pleasant experience, and I use one technology on one and the other on the other, from a practice perspective, that would be very difficult for me, and that's why I don't pick and choose. I mean, both work. I think the laser for my dollar is a little bit more flexible. I can use it in more circumstances than I think you can the closure system. The sheaths we use are smaller, make slightly smaller holes, although at the end of the day that probably doesn't much matter. Again, I just think you have to find the support that's going to really help generate and allow your practice to thrive. There was a question way over there. Yeah.
Go ahead. Yes.
Often it's not. And we can't get approval to do scleral perforators. Have you guys have you seen this and what did it recommend?
Is there one particular insurance or a cross section or?
I mean, I think I know the chief medical officers for at least 3 or 4.
Which area of the country are you?
I'm in Atlanta.
Atlanta. So really what happens is, because I have friends in the consulting and insurance business, and again, it's all about money, right? So what they do is they look at their profiles of where the biggest money is going out. And so somewhere in your area, those insurance companies saw that they were taking big hits on this when they just let it through the open. So they're probably asking for it. And what you got to realize is the reviewers have a document in front of them. And I know some of these reviewers. They have no idea what you do. but they're looking for key terms. So if you say phlebitis, ulcer, and related to that, and you show them some documentation, they will follow it. Whether it's right, whether it's logical, doesn't matter. So if you have an article that shows it works, and you tell your patient that, I'm taking care of you, that's your insurance company, you can go complain either to your employer, that's the one you'll sign up with, or to some local governing agency, they start responding. But just battling with them, remember, they are not your insurance company. They are the surrogate for your patient paying you. So when you tell your patient that and the patient complains, patient is their customer, they'll respond. But you'll have to play that game of the key words which are important, finding an article. But because the word sclerotherapy in the entire media and everywhere else is about cosmetic and just doing cosmetic work. I don't know what your comments are.
Yeah, no, I agree with you completely. I mean, I think that the documentation is the utmost importance, and they are truly just looking for certain words, and yeah.
Isn't it intellectually dishonest to say I go to a lake perforator and my breath stay with
No, we're not asking you to lie. I mean, that's not what I do. What I'll do, though, is if I see an ulcer, I say there's an ulcer, and I document it accurately. If I see, one of them actually asked me, because I explained all this to him, he says, okay, doc, can you tell me, is there dermatitis? Is there lipo, something, This guy had no clue. And what insurance companies are doing now is they farm this out to other consulting companies, and they tell them, we are spending X amount of dollars on this, we want to reduce the number. It's same with MRI, somebody asked the question. Then when your request goes in, they just send it out to somebody, and a doc who's sitting at home, primary care, nothing, has a document that says, if it says this, approve. If it says no. So you should document the correct things. Then if you really want to take care of that with ablation or sclero, you tell the patient you got to pay for it. And if they don't like their insurance, switch to somebody they'll pay.
Yeah, I think that there's a couple things. One of the things that I do is in all my notes that I do, I always put the SEEP classification in there. If you're not familiar with it, it's a CEAP is a standard classification that describes the venous disease. Typically for medical justification, you have to be SEEP 4 or higher. Rarely they'll pay for SEEP 3 or less for medical necessity. Otherwise, it's considered cosmetic work, so I always put SEEP classification in my document. I put things like how long have they been in compression stockings, because if they've not been in them for 90 days, they're not going to pay for it unless they are SEEP 5 or 6. Sometimes some insurance companies will pay for it sooner, but there's certain things that if you put in your documentation, the insurance companies will be more favorable. We typically don't get denied as much as what it sounds like you are doing, but usually I'll make a statement to the effect that this patient has an ulcer, they have chronic venous disease, they're SEEP class 6, they've been in compression stockings for this long, they're a candidate for venous ablation. I don't describe what type of venous ablation they do, whether it's RF or laser or sclerotherapy. I mean, the fact is you're ablating the vein regardless of the technique, so I don't think that's a problem. But you have to be careful of the wordage you use, I think.
Not to belabor a point, but I will. All insurance companies have policies and procedures. And once they've established a policy and procedure, it really doesn't matter what you send them, it's going to be denied. So for instance, Blue Cross Blue Shield Empire, the New York plan for New Yorkers, they view ablation of the anterior accessory and posterior accessory branch of the saphenous vein as experimental. It really doesn't matter what you send them, they view it, that's their policy. Someday they'll all sit around and they'll change their policy, and it won't be. But many companies view treatment of perforators as experimental. So at the end of the day, you can waste a lot of time and money going to bat for your patient, but the answer is what Romy suggested is some patients just wind up having to pay good old-fashioned cash. You can decide how much you want to discount or have them pay depending on the patient's financial circumstances, but then they're going to make a decision about how badly they really want to do it.
Yeah.
Tell us about perforators. How do you treat them?
All right,
Okay, well, I'll start off by telling you that for every 100 saphenous vein ablations I do, I treat 2 or 3 perforators. So I
Yes.
think that in the world of this, because it's currently so lucrative that a lot of perforators are getting treated that don't. In my practice, perforators, I call it kind of the advanced course. I mean, it is really hard to cannulate a perforator. It's really hard to thread a laser fiber or radio frequency fiber into a perforator for the most part because they're fairly short. So I would say in my experience, I wound up treating about half with sclerotherapy, and I treat half with the laser. And the ones that I treat with the laser are ones where I see at least a centimeter of fairly straight perforator vein that I think I can get a catheter in and ablate it above the fascia of the leg. If you're putting your heat device below the fascia of the leg, you have to remember, not only is there a junction between the perforator and the tibial vein, but there's an artery right underneath it, and there's a nerve right underneath that. And so if you're ablating things underneath the superficial fascia, you're going to wind up with some pretty serious injuries, either arteriovenous fistula or intractable neuropathies.
So I'll make one comment, and then we got to move on here because we got the next session, John. Bottom line is, if a vein is damaged and refluxing and causing the hypertension, it needs treatment. And if there's a perforator that has a lot of reflux, so I get a lot of patients from wound care, massive wounds, and the saphenous, there's several, yes, the saphenous is refluxing, I shut it down, but they've got 5 or 6 large perforators. Then I go from the largest and I shut them down. I used to do what John did with sclero. I had one patient where I did the sclero, everything was fine. 2 weeks later, he has a massive PE. Luckily, he survived. So since then, I've been very careful. So I use both laser and RF. I've gotten better with RF now, where I get into the perf, add the fascial plane, zap that shut, and then if there's a branch outside, I will foam sclero that so that the foam doesn't go in. But anyway, having said that, do you have another follow-up quickly? Sure.
What's your success rate?
It's very high, and I have folks who have actually been in my room watching that who will tell you. So we're in 95+% rate in terms of success with this. We can talk about this offline. It's just that I know we have to keep moving. No, only what's refluxing and damaged. If it's a normal vein on top, I don't. There are patients, I've had one patient where the large, literally bigger than the GSV perforator in the lower thigh, feeding his GSV and everything below. I don't need to shut down what's on top. Yeah, it's a normal vein, be collateral somewhere. Some disagree, but that's what I do.
I will disagree.
Yeah, I will too, but that's okay.
Okay, like I said, because if you look at it,
I'll tell you,
competent junction, competent valve, everything is fine there. You've got, for example, if you move down another few centimeters, then you should shut everything down the first day you see them. That's a debate for another time.
Oh, yeah. Well, I would say, in the patient, there's a few. I've probably treated the calf portion of the saphenous vein alone probably 5 times. Because it's very rare you see a patient that has just isolated calf reflux. But if they have reflux that extends up into the thigh, the mid-thigh, the upper thigh, but not right at the junction, at least that there's a high likelihood that they're going to have reflux at the junction. So I treat the entire saphenous vein. Not to disagree with
but what I'm saying is if that reflux is coming from the perforator, I don't need to shut down that saphenous. It's the perforator that it's like a SFJ. So I shut down that perf and the segment that's with it. Now, if there's a normal saphenous lower down in the leg and normal saphenous upper in the leg, why do I need to shut the whole saphenous down?
I think we're talking about 2 different
Yeah,
circumstances.
I think
Maybe he's talking about something different. I was describing something different.
Yeah.
All right, I think, but we should probably, we'll have,
Yeah.
You get the final word.
I get the
All right.
final word. Well, I agree with what you're saying about the perforators. In my practice, it's probably way less than 5%, low single digits. I mean, typically with ulcers, even bad ones, if you treat the proximal stuff in the greater saphenous and small saphenous, the majority of times those ulcers are going to resolve. So that's one thing. I think the talk about treating perforators is more sexy than it really is, and I think a lot of them get treated that may not necessarily need to be treated. But But otherwise, I don't disagree with anything that was said about treating perforators themselves. I think it's a technique issue that you have to really be careful because you can do damage, particularly to the artery. And one of the fears that I've always had in doing those is that if you thrombose that artery and people have for significant peripheral arterial disease, they're going to be left with a necrotic foot really fast. And so it's something you have to be really cautious of.
Oh, excellent. Our next speaker is Dr. John Golden. We're going to talk about tumescent anesthesia and other techniques.
If we could turn the lights down, please. Do you have a flipper?
It should be right on top there, isn't it?
I'm having this male thing. I don't have a remote in my hand, and I'm very uncomfortable.
As always, the female took it intentionally.
My wife was always fighting me from it before she usually went. Okay, so I guess the rest of the afternoon, a lot of it is me, so I'm going to hope you guys don't get too bored. But so the first thing that I was asked to talk about is tumescent anesthesia and other techniques, and it kind of took me a while to figure out what other techniques meant, but you'll see my answer in a few minutes. So tumescent anesthesia was really first described by Dr. Klein, i.e. the Klein pump, who was a dermatologist, in a paper he described in 1987, and he did it to learn how to do office-based liposuction. And basically it exploits the principles of pharmacokinetics to achieve anesthesia of the dermis, the epidermis, and the subcutaneous tissues, all in an outpatient setting, although it can also be done in the operating room. For the purpose of saphenous vein ablation, whether it's with radiofrequency or with laser, it does three things, and you've heard this. It provides local anesthesia, it provides vasoconstriction. It allows the vein to get as close to the heat-generating catheter as possible, and lastly, it provides for this heat sink. When radiofrequency was first done in the late 1990s, it got a bad rap because it was done in the operating room under general anesthesia without any tumescent anesthesia, and that's when all the patients got thermal burns and saphenous nerve injuries because there was no heat sink to help divest the heat away from the vein being treated. So just a brief review for you all, or maybe for some new, but remember there are two types of local anesthetics depending on what kind of carbon bond links the two molecules in the local. They're the esters, of which cocaine, procaine, and tetracaine fall in the category. Procaine is more commonly known as Novocaine. And they're not used in what we do because they have a fairly long duration of onset of action. In addition, if someone, they're hydrolyzed by esterases, and in someone with a pseudocholinesterase deficiency, they can have prolonged duration of action. The amide locals are what we use, and lidocaine is pretty much the one that we use exclusively. And the advantage of lidocaine is it has a very rapid onset of action. You give it, and literally a few seconds later, it has blocked the transmission of pain sensation through the nerves. The one thing you have to be aware of is that lidocaine is metabolized in the liver, so if you have someone with cirrhosis or liver impairment, you have to be just a little bit more careful. Another thing you should know about lidocaine, and I actually just learned this, so maybe you guys do or don't, but there's two types. There's a single dose vial, which has no preservatives in it to it. They have something called methylparaben, which actually serves as a preservative in the multi-dose vials, a vial you can aspirate today and use again tomorrow. And most of the patients who are allergic to lidocaine are probably allergic to the preservative. So if you have someone who says they're allergic to lidocaine, you should give them a test dose or send them to an allergist and give them a dose to the preservative-free lidocaine. And in the majority of circumstances, you'll find that you'll be able to use a preservative-free variety. Another interesting thing is actually lidocaine in low concentrations is bacteriostatic. So that may explain one of the reasons why we see so few infections after any of these procedures. And lidocaine in very high concentrations, which we don't use in the tumescent version, is bactericidal. So what's the maximum dose of lidocaine? Well, if you look at the IFU on the package, you'll know that 5 milligrams per kilogram without epinephrine is a safe dosage, and 7 to 8 milligrams per kilogram with epinephrine is a safe dosage. And that works out to roughly, As you see, 400 in a 80 kilogram pail without, and 560 in an 80 kilogram patient with. Dr. Klein has written that actually 35 milligrams per kilogram is safe when used in the tumescent version because it's in fat, there's slow absorption and the like. But I will tell you again, from a medical legal point of view and the IFUs, I don't think anywhere in the drug manufacturer's literature will it tell you that these large doses are safe. So I restrict in my office using basically 500 milligrams per kilogram per treatment. And what that basically allows me to do is if you know that basically 1% lidocaine is 1 gram of lidocaine and 100 cc's of saline, a 50 cc bottle of 1% xylocaine or lidocaine has 500 milligrams of lidocaine, and that's what I use in my tumescent. So there's all sorts of concoctions of tumescent anesthesia out here, but this is the one that I use, and we basically take a 500 cc bag of normal saline, we aspirate out 60 cc's, to which we add kind of a little bit of a concoction. We add 30 cc's of lidocaine without epinephrine and 20 cc's of lidocaine with epinephrine. The epinephrine is diluted 1 to 100,000, and this is a slightly acidic solution, and so you need to add some sodium bicarbonate. As you all know, there's been a drug shortage of a variety of drugs for a period of time, and actually a year ago, you couldn't get sodium bicarbonate. So I got the opportunity to find out whether it really made a difference, and were patients more uncomfortable being treated with a tumescent solution without bicarbonate, and the answer is yes, they're a lot more uncomfortable. So the bicarbonate is key. Now the reason originally we used to use 50 cc's of lidocaine with epinephrine, but when I switched to an infusion pump, it was very easy to give patients intravenous boluses of lidocaine until I became more facile with it. And with that large dose of epinephrine, a lot of patients got tachycardic, jittery, nervous. So we took the epinephrine out, and even with that, 2/5 concentration of epinephrine, you still get adequate vasoconstriction and duration of action. Romy, did you have something you wanted to?
No, please continue.
Hand
It's okay.
signals?
I'm just trying to get Pat's attention for a moment.
Okay. And you guys have
Could you come
probably
up-
seen this slide 100 times, but when you're giving tumescent anesthesia for saphenous vein ablation, you're giving it in the saphenous compartment, which is indicated there by the two brackets on the inside. And when you're giving it to anesthetize for phlebectomy, which we're going to actually talk about later, you give it in the subcutaneous tissue. Tumescence refers to turgidity or swelling of tissue, and when you give a high enough concentrate or high enough volume in the subcutaneous tissue, the anesthesia diffuses into the dermis and provides complete dermal anesthesia. So when you're using tumescent anesthesia, you actually never give any in the dermis. It's all given either in the subcutaneous tissue or in the saphenous compartment. So it's different than the typical anesthesia that you're used to for skin moles. And this is just an example, slide from a long time ago, using a 30 cc syringe and injecting tumescent anesthesia along a vein that I'm about to do a phlebectomy of. This just shows a couple different, the other two ways that you can do it. And option A is on your left side, and that's called an auto refill syringe. And it basically is a 10 cc syringe with a one-way valve on it that allows you to aspirate lidocaine from a bag into the syringe and inject lidocaine through it. When you're using an auto refill syringe, you have to use either a 20 or a 22 gauge needle, otherwise you will have hand fatigue and arthritis of your thumb very quickly. And that's one of the disadvantages of it, is because every time you stick a 20 gauge needle through the patient's skin, it's going to hurt a fair amount. So if you use this technique, usually what I did back when I used to use it is I would put little wheels of anesthesia in with a 25 gauge needle so they didn't feel the needle stick. A better technique, though, is to actually use an infusion pump, and there's a variety. Dr. Klein's pump is the one on the bottom, but I believe there's a variety of companies that manufacture them. They cost about $1,000 a piece. And the beauty of it is, while those of you doing this have been taught that you need to use an 18 gauge spinal lead to give your tumescent anesthesia or a dedicated tumescent anesthesia needle, I actually use an 1.5" 25 gauge needle to administer all my anesthesia for vein ablation. And that way the needle sticks through the skin, are almost painless for the patient, and it infuses a lidocaine at a much slower rate so the patients don't get nearly the amount of discomfort from their tissue being acutely stretched. So for me, the infusion pump allows me to use a smaller 25 gauge needle, and it works in about 98% of patients. About 2% of my patients are so heavy or their thighs are so thick that that won't get into the saphenous compartment, but in the remainder it will. The complications are really very few. From lidocaine toxicity, you can see you can get visual disturbances. The one that you get concerned about if they get a rapid infusion of lidocaine is seizures, but that requires a large volume of lidocaine given very rapidly. Remember, when you're using tumescent anesthesia in the formula that I use it, you're actually using 0.1% lidocaine. And so it requires a large volume of lidocaine to have a toxic reaction. And as I stated earlier, the most common side effects from intravenous administration or from tumescent anesthesia is giving intravenous lidocaine because with either the auto refill syringe or the infusion pump, you have no ability to aspirate and see that you're in the vein. And the way you determine it when you're giving tumescent for the saphenous vein ablation is you're actually looking at the vein as you're doing it. And if you're in the vein, you'll see the vein dilate and you'll see a bunch of little air swirling around inside of it. If you're giving it for phlebectomies, if you don't see the skin immediately swell up as you're giving your tumescent, you'll feel the skin and you'll feel the jet as the tumescent is getting pumped inside the vein. So you need to be careful. So that's really about, I think, what you need to know about tumescent anesthesia. So when I thought about other techniques, I thought, well, if you're going to do heat ablation, there is no other technique that you can do. But many people feel that the limitation of heat ablation techniques is the fact that you have to give tumescent anesthesia. Now, I would say that for me, being someone that does phlebectomies at the same time as his vein ablations, I have to use tumescent no matter what I do. And I'm not sure that all these newer technologies are necessarily an improvement, but you do need to know about where people are going and what's being looked at. And I think that Dr. Thorpe is actually going to talk a little bit about this also in a little bit, so I don't want to steal her thunder, but I would tell you that the one approved device is the one you see here, called the Claravane device, and that's a device that has a long catheter. At the end of that catheter is a little, I call it an egg beater, but it has something that whips around the inside of the vein to help disrupt the intimal lining, and at the same time you inject sotradecol along the vein as you slowly pull the catheter out. It requires no anesthesia, and other than the needle puncture to put the catheter in. And it is an FDA-approved device. However, when you look at the literature in this particular study here, it looks as if it's a pretty good device, but at 6 months, only 90% of the veins are occluded, and so it may not be as good a device as the heat ablation devices that we use currently are now. The rest of the things I'm going to talk about are not FDA approved, but they're just sort of out there, so you should know about them. And one is glue, and this goes by the name of, Pat, help me here.
I don't know the...
well, it'll come to me in a second, but...
I just call it that.
Anybody know what the name of glue? Well, anyways, they use cyanoacrylate as a glue, and the advantage is it's tumescentless, it's minimally invasive, it doesn't require any compression, you don't have to buy any expensive equipment. The downside to it is that there's really not a lot of long-term data yet, and if you require a varicose vein procedure, which I do simultaneously, it's not going to work for you. That's the device that is out there. And you can see basically the glue creates an inflammatory reaction, almost like sclerotherapy, which leads to eventual obliteration of the vein. Here's an early study by Dr. Almeida, where he looked at 30 patients followed for 30 days, and basically they inject the glue. And the remarkable part about it is how little volume of glue you have to put in to secure to seal the saphenous vein. The average volume was 1.3 cc's. I mean, it's remarkable. But basically, on their patients who were followed up at 30 days, 97% of the veins were closed, and of the 8 patients they followed up for a full year, all of those veins were occluded at that time. So that's something that you're going to hear people talking a lot about. It's not FDA approved yet. There's some clinical studies going on related to it, and the name of it's going to come to me before we are done here. It's not called Claravane, it's called, anyways. And the last thing we're going to talk about is foam sclerotherapy. So foam has been around for a long time. We're going to talk about a little bit in sclerotherapy. But basically, you take a couple syringes and you swish it back and forth. with one of the detergent sclerosing agents to create a foam sclerosing solution. The problem with foam has been several, and if you look at this study, you'll see that at 5 years, the closure rate with foam is 73% versus 95% with a laser. But one thing to remember is that 75% of the veins remain closed with homemade foam at that period of time. The advantage of foam is that it's a lot less expensive than all these other techniques, because all you really require is some ultrasound and the foam itself and a simple syringe to use. But I have to point, the downside to it is foam can get systemic, and in people with right to left shunts, there are lots of reports of strokes, visual disturbances, and the like. The only thing I can say is that there is a company that currently has a foam product before the FDA, which may be approved by the end of the year, which, because of the way they have manufactured it, may well get approved and may well put foam back on the market, but that's something that is not currently approved. So in conclusion, tumescent anesthesia is a safe, effective means of providing large area local anesthesia. Newer techniques have the potential to treat saphenous reflux without tumescent anesthesia, but they do involve injecting foreign chemicals for success, and long-term follow-up is necessary. Thank you.
Thank you, Dr. Golan. There's, Dr. Bush talks about using minimal or a tiny amount of tumescent under his spider vein injections. Are you familiar with that application? He thinks it compresses raises up the spider vein to the surface and compresses it from below.
Correct. So sometimes, when you're doing these vein ablations, for instance, there's all sorts of creative things you can do. And so one of the things that I'll do is, as long as I have 47 seconds left, if you have a patient who's had a saphenous vein ablation, a vein stripping in the past, and they have a neovascularized saphenofemoral junction, they have lots of veins in the thigh, but you find they have a residual 15 centimeter segment of vein in the calf, I will treat that vein with a laser, but before I put my laser fiber through, I'll actually inject some Sotradecol through the end of the fiber, and it will fill a lot of these venous tributaries, and then I will tumesce the area to actually get the vein to constrict around the sclerosing agent. And we've also done it. There are some people who write about tumescent-assisted sclerotherapy like Dr. Bush, where ideally once you've injected the solution, it's more effective because you're going to make the vein actually constrict around the solution. We've tried it and had limited success with it.
Okay, thank you. Any other questions, Dr. Golan? Okay, thank you. Oh, one more.
Good job.
Sorry.
What is your treatment approach for large perforators coming out the popliteal vein? And small saphenous reflux?
Right. So my approach for both of those, the small saphenous I treat with endothermal ablation with a laser, and the we call them popliteal perforators, and frequently you see those in patients who've had a small saphenous vein stripped, or sometimes there's small saphenous is normal and you just see this large vein with severe reflux leading to all the varicosities, and I'll treat that with a laser perforator kit, or the same thing you could use, the radiofrequency perforator kit. What I would tell you, you have to be exquisitely careful about, though, is the popliteal nerve is directly posterior to the popliteal vein, so you have to be very careful to not get your fiber within a couple centimeters of that neurovascular bundle. And remember also, the perineal nerve is coming laterally there. So again, they're just things that you have to think about. If you have plenty of tumescent around it and you're at least a couple centimeters from the popliteal artery and vein, you should be okay. So.
Thank you. Well, we're going to move on to the next session right before our afternoon break, and I invite Dr. Hunter to come up. And actually, we're going to probably talk about some of the newer ideas, and expert panel discussion may be a misnomer, but I think that there are some ideas out there for thought. And I have, did you have any slides? No. I have a couple of slides I'll just show just for some information, and then we can hear what Dr. Hunter has to contribute here. I'm not doing any of this, but I wanted to share the information with you because I was at the European Venous Forum 10 days ago, And they had some abstracts presented, one from a Japanese group and one from the British, or the multicultural group, multi-country group anyway, in Europe that was doing the cyanoacrylate, which is impressive in that you really have so little stuff. But what I'll present first is this abstract from Japan. This is an animal model, so it really is an evolution, but there may be some potential for the future. High intensity frequency, focused ultrasound. And what they did is they developed a model, an animal model with, I believe, rats and or rabbits. But the high intensity focused ultrasound has been used for solid tumors, fibroids, and for prostatic hypertrophy with some success. It creates quite a bit of heat, up to 90 degrees in the focused beam of the ultrasound, with a very superficial megahertz transducer. So you're very close to the problem. One of the downsides, of course, is you can get skin burns if you're treating the saphenous. But you can induce an acute closure, and what you do go from space to space, a couple centimeters apart, and you beam the high-intensity ultrasound, and you damage the endothelium and get thrombosis. So I thought that was something that they're working on, and we can just sort of open up the discussion about that and this cyanoacrylate here. The cyanoacrylate embolization, these are the data from the group in Europe where the countries involved, Germany, UK, Netherlands, and Denmark. And they presented their year follow-up data, although the median follow-up was 6 months. They went from 6 to 12 months total. And they duplex their people every 3 months, and you can see the data here. The median diameter was 8 millimeters, and the median age of the patient, 48. They didn't have the breakdown of male-female, but the median volume is 1.3 millimeters, which raises the question of how powerful putting glue in your vein is. It induces an immediate, powerful inflammatory reaction. And the median length of the treatment segment was pretty short compared to what we do with radiofrequency and laser ablation. It was only 4 centimeters. So the downside, of course, is that there is a lot of inflammation, and if you have a patient who has allergic reaction, that can be drastic and cause a lot of thrombophlebitis. But at 2 days, they had 100% closure. Sorry, that's 100% occlusion. Partial recanalization occurred at 3 months in 3 out of the 70. So they had continued closure of 95%, but at 6 months, they only had 48 patients available for a 6-month follow-up, and it was 93% complete occlusion. Almost 10% phlebitis. Very low incidence of thrombus, a minimal thrombus, which didn't do anything to that patient. So as far as I could tell from listening to the discussion there, and then Dr. Almeida has his preliminary data, Dr. Morrison in Phoenix is participating in the multi-center trial in the United States, where the 1-year data will be presented relatively soon. And they'll have probably similar data, but seemed pretty neat. If you don't need tumescent or compression, it can be a lot faster procedure. The patients would like that. But whether or not, they say you can test people to see whether or not they're going to have a reaction. Personally, this is the same kind of crazy glue or glue stuff that they do for acrylic nails or artificial nails, and myself included, just a drop of that glue causes a severe dermatitis within 5 minutes on my fingers. So I'm very sensitive to it, and I'll just stop here and see if both Dr. Chopra and Dr. Hunter have comments about this or any other topic. Dave?
The only comment I've had when I've listened to people talk about using glue for this is that we've used glue, as you know, in vascular malformations for a long time. And I'm not sure what they're doing to inject the glue unless they're completely collapsing the vein ahead of time, because if you just calculate out, if you had an 8 millimeter vein extending down for any length of distance, for every centimeter you need a half cc, just on a pure volume, if you're going to touch every wall and induce some sort of adhesion or inflammatory reaction in the wall. So how they get away with doing 30 centimeters worth with, 1.5 cc's to me seems a bit, odd, unless they can totally collapse the vein. We've watched it in vascular malformations and other abnormal vascular structures when we've injected it, and it does induce a small amount of spasm, but not nearly as much as other sclerosants. The other downside of glue, having put glue into a variety of vascular malformations that are in superficial areas, is that you have an eternally uncomfortable lump. I've had patients that complained about that lump under their skin or in their subcutaneous tissues or superficially in muscles where they've had muscular malformations for 5 or 10 years afterwards. And in the hand in particular, it's a real problem. So I have just a few problems with glue. One interesting thought that we've had in just discussing new techniques at the University of Minnesota is that we have a company, a small company that manufactures one device currently, but has other devices on which we have intellectual property. And one of those devices is a special kind of perforator clip that you could put on under ultrasound guidance to just clip perforators. And we were talking about that device the other day in terms of working on saphenous veins, and we thought about the fact that you could clip very precisely the greater saphenous vein at the point where you don't want anything going north, and then fill it up with something that's completely non-toxic, like some of these bubble solutions that contain a sclerosant. When you're happy about where they are, then you just either ultrasound them to essentially burst the bubbles and deposit the sclerosant in the area where you have actually injected and ultrasounded. And you could just control your movement of bubbles because they're so visible ultrasonographically and sonographic deposition of sclerosant, and you'd never have to worry about them transgressing the cephalad end into the saphenofemoral junction or the femoral vein because of the fact that you've already put a clip on it. And the clip application in our animal experiments takes about, 2-3 minutes.
I think one factor is...
Removable? Excuse me, is it removable? You remove it?
Actually, in animals, you can remove it. It's not designed to be removable. But we've done it just to see if it's doable. It's doable because it's applied. You can vary the force that you apply it with.
I think one factor that has to come into play, which we don't discuss this while innovating, is the cost. Because there's some places where Medicare is only paying $1,200 for an ablation. And by the time you add all the overheads that you have, there's hardly anything. So any innovation's got to be either really a breakthrough innovation that surpasses all kinds of other boundaries and involves a high cost, or it's got to be cost effective. And glue, from what I remember, medical glue is very expensive.
Oh yeah, right now for at the VA, where we do buy glue for a few things that we do, the vial of glue with the associated opacifying thiodol, that packet costs $4,500.
Wow.
So, and
like per cc.
Yeah. So I think that's definitely an issue in terms of how, and really the question comes down to is, when you're using glue, why are we thinking of glue as in a safer alternative, a faster alternative? What's the better part, which is what I don't know yet? Or is it just another way to do it?
Well, what they say is no tumescent and no compression afterwards, and you get equally good results. So that makes it faster.
So is it really bad to have tumescent?
Well, it's just, I think it's a volume thing. I mean, in terms of throughput, it takes time to do that.
I do 10 ablations a day. I can manage it. So I'm just trying to debate that point to see, why do we want to come up with something more so expensive? Is it just another use for that widget that's already out there? Or is it really going to make something so safe that you come in and you're done in 5 minutes, it's worth the $4,500? Or is it unbelievably safe? Here I'm worried this glue is going to be a lump. If it goes up to the lung, it's stuck there. In the wrong hand, somebody's going to stick something to, super glue. This is super glue that you get in the market as well.
Yeah, your catheter can get stuck.
Yes,
easily.
there's so many things that can
the glue
happen.
that we have is difficult to use because its polymerization time is so fast, even if you add a fair amount of ethiodol. But but there's a new glue in Europe that I just heard about a couple months ago, where there was a European person presenting at a conference where I was, and that glue costs about, I forget what it was, but it's like $100 to $150 period for a 2 cc version instead of a 1 cc version, and it's got a much longer polymerization time, so you can essentially treat it like onyx. You can watch it, your catheter tip doesn't get stuck in it, you don't have any risks of it going places really you don't want to, because if you were doing it in let's say the saphenous vein, you could just sort of put your finger on it, and it definitely sounds like a huge advance, but right now it's being blocked by the FDA.
Well, if you take what you said about that glue being a better glue, and you know how easy it is to hit the saphenous vein because you're doing this tumescent and you're trying not to hit it, but it would be really easy just to hit it with a 25 gauge needle. If you don't need tumescent, you could just go spot injection of acrylic every so often. You don't even need a catheter.
So I'm sure, for example, in the ablation that I do, I can be done in 20 minutes with everything.
Mm-hmm.
So, and the patient, I play music in the room, I'm joking with them, everything's done, they all drive home. So
But the
to
cost
me,
of the catheter is
but
significant.
you're making my point is that now the cost for the entire procedure, I'm paying about $300 a catheter, and I have overhead costs and everything else that comes in. If I'm going to buy glue at $4,500 a cc, now I need 5 cc's, that's a whole different ballgame. So there has to be some equation. I think John has a comment there, but.
So first of all, the name of the product is called Sapia company, so that's the name of the product. And secondly, you know that at the end of the day, it's going to cost somewhere between $300 and $600, the price of a laser camera when it comes out. So, but the other problem with some of these new products is while they're FDA approved, for instance, Claravane, the catheter that screens the socodecol as a construction, it's FDA approved, but the company has never done comparative studies. So most insurance companies won't approve the procedure because it's unproven technology. So some of these things will be the same way with the Sapien procedure. You have to come out, not only have something to show it's safe, but these days you have to show not only it's safe, but it's as effective or more effective than existing technology.
Yeah. So I think if I'm thinking as an innovator, well, thanks for your comments on that, but if I'm thinking as an innovator and not worried about commercialization and cost, I just want to, then it's one thing, we'll play with this and then the cost will come down. But then it has to be exponentially better than the first one.
Or equally good.
Oh, equally good, but then what's the difference for me? That's my point, or to the patient. So equally good, maybe there's still a chance if the other one goes out of business, I don't have it. But I think till that happens, it probably won't make much sense to me, at least. I don't know about
No, I agree.
A lot of the patients, we know that there's a lot more bruising associated with laser, but at the end of the day, 2 weeks later, the results are similar. Has that ever deterred you from using laser, or do you prefer?
Well, I think that was probably the case with the lower frequency wavelengths, but I think that with the 1470 nanometer laser, patients really have almost no discomfort, no bruising. So I think the procedures are kind of equivalent in terms of success, post-op discomfort. So
Okay. Well, I think that we should have a nice break here and be back here exactly at 3:15 to hear Dr. Ossie talk about Brazilian method for sclerotherapy. So I think there's some break, refreshments right outside the room. And thank you, everybody, for this session. Thank you.